All right, well, I'd like to say good afternoon or good morning, depending on where you happen to be, and welcome back to day 2 of our public meeting on safe use of benzodiazepines, clinical, regulatory, and public health perspectives. This webinar is being convened through a cooperative agreement between FDA and the Duke-Margolis Center for Health Policy. I'm Mark McClellan. I'm the director of the Duke-Margolis Center, and on behalf of Adam Kretsch and Mira Gill and the rest of our team, would like to again welcome you all back to joining us for this very important and timely meeting. We are hearing from a diverse range of perspectives, including clinicians, patients, researchers, regulators, and others, on how to effectively balance the benefits and risks of benzodiazepines and ensure that they are used as safely as possible. Yesterday, we heard a series of presentations reviewing the available epidemiologic data on benzodiazepine use, abuse liability data, as well as clinical use. We heard reactions from a range of perspectives, including clinical and pharmacologic and public health experts, as well as some presentations of additional information on understanding risks associated with use, misuse, and abuse of benzodiazepines. We heard that benzodiazepines have potential for abuse alongside their benefits in certain clinical contexts, and that non-medical use of benzodiazepines contributes significantly to morbidity and mortality as well. We took a close look at differences across the benzodiazepine class and heard from a variety of perspectives on whether certain benzodiazepines, particularly alprazolam, may carry greater risk than others in the class. And we also examined the use of benzodiazepines in clinical practice. These drugs have clinical value in treating certain conditions, as I mentioned. Those include acute anxiety, alcohol withdrawal, epilepsy, but concerns remain about appropriate use of benzodiazepines, including their long-term use and the co-prescribing of benzodiazepines and opioid analgesics, as well as effective approaches to tapering and discontinuing benzodiazepines, a topic that also had extensive discussion yesterday. Across all of these conversations, we identified some key gaps in our understanding and identified a number of critical challenges to effectively balancing benefits and risks and maximizing the net benefits of these products. And we want to build on these discussions today as we have a chance to expand on many of the topics that came up yesterday in the panels and the discussion with all of you that's going to follow. So we look on the slides at the meeting agenda for today. We've got 2 major sessions. Session 3, which will feature 3 presentations related to clinician-identified best practices and gaps in education, including a discussion of FDA's work in this space. And then session 4 will focus on synthesizing some of the key takeaways from the meeting and the next steps in balancing the benefits and risks of benzodiazepine use. Just a few reminders before we get going again. You can visit the Duke-Margolis event website for materials from today's meeting. That will include the recording after we're done, as well as the materials that are presented. If you have any questions for the panelists, you can submit those through the Zoom Q&A function at the bottom of your screen. And I just want to thank all of you who did submit questions, as well as comments and perspectives on yesterday's discussion. That was very helpful for increasing the robustness and the range of the topics we talked about. And I hope people will feel free to contribute again today, and we'll try to get to as many of those as possible. Because we are recording, we want to remind our speakers to please check that your camera and microphone are active before you're speaking. If you have any difficulty activating your microphone before speaking, our production partner can remotely activate and deactivate your microphone on your behalf. And also as a reminder, when you're not speaking, if you could stay on mute to minimize the background noise and activity. Also as a reminder to the presenters, Thomas Rhodes will be advancing the slides today. Remember to provide a verbal cue. Just let him know when you're ready to move to the next slide. And additionally, Mira Gill will be providing timing reminders to our speakers and panelists through the Zoom chat function too. We encourage all of you to join us not only through the Q&A, but also on Twitter at Duke Margolis, or you can use the hashtag #SafeUseBenzodiazepines. Safe use benzodiazepines. So with that, I think we're ready to move on to the first session for today, or session 3 for this 2-day meeting on key themes emerging from replication efforts. So this is focusing on health professional, patient advocate perspectives, I should say, on best practices, experiences, and concerns. To kick off this discussion on best practice experiences and concerns from health professionals and patient advocates, we've got 3 presentations. First, we'll hear from Stephen Wright, who's the medical consultant for the Alliance for Benzodiazepine Best Practices. And Stephen, thanks for your chat and Q&A contributions to the discussion yesterday as well. Barbara Farrell is our second speaker. She's a pharmacist with the Briere Continuing Care Geriatric Day Hospital and senior investigator with the Briere Research Institute in Ottawa, Ontario, Canada. And next, Sangeeta Tandon, who's a pharmacist member of the Professional Affairs and Stakeholder Engagement staff in the Office of the Center Director at FDA. After those 3 presentations, we're going to hear from 4 panelists before diving into a moderated discussion. Our panelists for this session are Chinyere Ogbonna, who is the Medical Director of Addiction Medicine and Recovery Services at Kaiser Permanente San Jose, and adjunct faculty member at Stanford University. Sumit Agarwal, who is a physician and health policy researcher at Harvard Medical School and Brigham and Women's Hospital. Christy Huff, who's cardiologist and director of the Benzodiazepine Information Coalition, and Scott Winecki, who is director of the Safe Use Initiative at the FDA. So great range of perspectives and a lot of people to hear from. Let's get started. I'd like to turn this over to Stephen Wright. Stephen?
Good morning.
Good morning or afternoon, yes.
Or afternoon, that's exactly right. Let's see if this works. Okay. Hi, my name is Steve, and I'm a recovering benzodiazepine overprescriber. It's true. I grew up in family medicine, started doing addiction medicine about 33, 34 years ago, medical pain management about 17 years ago, and along the way came benzodiazepines, and I did what my mentors, my attending physicians taught me to do. Use them, probably not in excess like we've seen in other circumstances, but nonetheless, as I was taught over a long period of time, and I found that indeed about 4 or 5 years ago that a lot of these assumed received knowledge information was really untrue, and so I acknowledge for those of you that are benzodiazepine survivors that hung in there with us when I wasn't listening in this particular space. And just like with opioids, we have distress among individuals that have pain, that have benzodiazepine use, and we get confused often as to which is causing the problem. Is it the underlying condition, or is it the substances that we're using in and of themselves? And I want to start out by highlighting an important thing, that for most individuals with BSRA-related problems, and that's benzodiazepine receptor agonists, because it includes benzodiazepines as well as Z drugs, as well as the barbiturates, that it is related to physiologic dependence and not so much addiction. We took a look at the addiction-related issues, non-medical use issues. That probably is not the most important feature, although we don't have data relative to the numbers in relation to that, but there are many out there. So disclosures, primarily I'm involved with the Alliance for Benzodiazepine Best Practices. I'm involved doing benzodiazepine activities in other domains as well, the Action Work Group in Colorado, NEMA Research, and some research initiatives through the Schreiber Research Group and Stater Opioid Consulting. The only commercial disclosure that I have, Cordon Health Solutions, drug testing and pharmacy services, which isn't relevant for our discussion today. So today I want to have some remarks about the best practices, highlight limiting duration to 2 to 4 weeks, and then outline some basic de-prescribing practices as they go along. So the best practices overall, we want to encourage limiting initiation. And for this, The supplemental slides outline that, and I put that in the Q&A in chat yesterday. Limit duration of use to 2 to 4 weeks, and there's a rationale for that. And then for those individuals that are on benzodiazepines or related substances, slow, safe, supported, and shared, though patient-led tapering to discontinue use. And we'll go through some of that as well. So prescribing itself begins with the informed consent, and that's a standard process that we use for all medications and all procedures that we provide to patients that encompasses the risks, the benefits, the alternatives, and I'm encouraging the use of a written informed consent, which is available through the Benzodiazepine Information Coalition site, as well as our site at the Alliance, and is authored by Christy Huff, who will be speaking on the panel here as well. And the other piece to this is how to prescribe benzodiazepines is really a relevant part of informed consent, how these are used and whether there should be, as I argue, limitations on their use as well. So what about the utility of benzodiazepines? Short-term efficacy has been well demonstrated, and we see that in many studies in many populations. However, we also know that cognitive behavioral therapy in relation to anxiety works just as well. And get this, it is durable 12 months after completion of the cognitive behavioral sessions. That's pretty great because we want durability of response with regards to the various interventions that we provide to patients. However, we also find that benefit often declines after that initial benefit is realized. And that's a challenge. We have not seen in good methodologic studies long-term efficacy. And this is a research concern for those of us in the field. We see when we look at the online communities that indeed those communities have expressed how benzodiazepines have lost efficacy over time. And in fact, we see a circumstance where benzodiazepine cessation actually can improve anxiety and seizures, and there are a number of articles that reflect that. And indeed, I think of this as an entity that could be called benzodiazepine-induced hyperanxiogenesis, but because we see on reflection retrospectively a cohort of individuals that get better with regards to their anxiety. And so this is the covert issue that my attendings never taught me, that indeed the medication, just like with opioids and opioid-induced hyperalgesia, there's a cohort of individuals for whom the substances actually create the problem intended to help. Even so, 80% of those that are on benzodiazepines and Z drugs have been taking them for more than 6 months. We heard of a study yesterday where 1/3 on long-term use. This is one that uses NHANES data published in 2018. In any case, the majority of individuals are on for a very long period of time. And I would argue without valid validation in the reflected literature. So what do we look at in terms of best practice? And these are just some of the highlights that I think I have learned over time. I think it's important to prescribe for indications only when individuals are functionally impaired. Just like with opioids, it's not just the symptom in and of itself, it's whether or not these symptoms result in functional impairment. And so that's the primary indication. At the same time, the benzodiazepines are prescribed, if they are, prescribe an alternative treatment. These very often take longer to work. And while you use the benzodiazepine short term to bridge the gap, bridging to the effectiveness of an alternative RX is often the way to go. Follow up then weekly with weekly prescriptions and discontinue by week 4 while the other alternative treatments are moving into efficacy. And then for the cohort of individuals that are on long-term benzodiazepines, discontinue benzodiazepines for all that are on greater than 1 month. Now, this is an offer that ought to be provided to individuals. It should not be forced, with the exception of one thing, and that's in the circumstance when individuals have identified respiratory depression of a significant sort. And this often occurs in relation to co-prescribing with opioids. And there it's really imperative for us to move towards discontinuations for the safety of patients. But the offer ought to be there to all individuals on benzodiazepines for more than a month that discontinuation can take place, and for them to consider doing that. Initiate the tapering, which we've discussed to a certain degree already, by reducing just less than 5% of the original dose. And the reason is that there is a cohort of individuals that larger reductions, and these have been described in studies, this cohort does not do well with a 25% reduction or a 10% reduction. And what can happen is that subsequently, if the 5% reduction is very easy and not a problem, you can enlarge on that in the prescribing space, but adjust this tapering amount and the frequency of reduction according to individual response. And this is important. This is patient-led. This upends the model that we usually have, where the prescriber is taking the lead on all this, but it is the expertise of the patient, their individual response, that really counts in terms of the amount of tapering and the frequency of tapering reductions. Listen, validate, and support. And it may take 12 to 18 months to complete, or even longer than that for some individuals. Benzodiazepine withdrawal is a different animal. It can take far longer than that for other substances, even years of this. I've heard up to 11 years and more in individuals, and it brings to mind the possibility that we're dealing with an injury syndrome, where there may be durable adverse effects for individuals over a long period of time. And this needs to be supported as well. Symptoms can be wide-ranging, severe, very unusual. They may seem to be quite bizarre. There's a tendency for us to think of alternative diagnoses or psychosomatic processes going on. We need to evaluate as clinicians the possibility of alternative diagnoses, but not to sit there forever thinking that the patient simply is in denial about an addiction which isn't there, or another diagnosis that indeed is not there, but to validate their concerns. Symptom patterns often fluctuate dramatically, and this is unlike any other substance withdrawal. In 1984, David Smith actually introduced the concept of this fluctuating pattern. Heather Ashton spoke to this in the 1980s about waves of worsening, windows of relative relief. This puzzles us. These are not necessarily environmentally stimulated, something bad going on in the environment, hopping up the symptoms that patients have, but they occur in these waves and windows, unpredictable and uncertain in terms of duration. It is usually not a benzodiazepine use disorder per se. And so addiction treatment is not helpful. We hear anecdotally of individuals entering treatment centers, and they are mystified by 12-step and those sorts of things, because craving is really not part of their experience. They're just having difficulties with the discontinuation process. This is unlike other addiction-prone substances, where we often see addiction as the background for the difficulties in withdrawal processes. So for those of you that are benzodiazepine survivors, this is not news. For those of us that are researchers, there are major questions that remain unanswered. That includes really redoing all of the studies way back in the day, because the methodology was off. And I understand we didn't know about how to do methodologically these various studies for efficacy or adverse effects, and then the background etiology and mechanism for physiologic dependence and injury as well as then to manage benzodiazepine discontinuation. There are a lot of ideas out there. The data is quite limited in terms of the options out there as well. And then for us as prescribers, much of the received knowledge about benzodiazepines I found to be untrue. And we need to recognize this. We need to acknowledge the experience, the lived experience that are expressed by our patients. We need to check out the alternative diagnoses, but not forever, and validate for these patients the reality of that. Update our knowledge in relation to that. Engage and allow our patients to leave. They have the expertise in their own experience that drives the process for how fast to move through a withdrawal process. and then to become benzo wise. That's what it means to be benzo wise in this particular space, and important to do that. And one last thing, there's a quote out there, pain is real when you get other people to believe in it. If no one believes in it, it's madness or hysteria. Naomi Wolf. She could have just as well said benzodiazepine withdrawal experiences is the same thing, because indeed individuals that are in this space and challenged by their experiences, and those of us in this prescribing space not recognizing and not validating their experiences, this is quite difficult. And so you feel free to reach out to me through my email, as well as through the Alliance for Benzodiazepine Best Practices. And I'm going to step away at this point. Thank you very much to Duke Margolis and the FDA for putting on this program.
Great, thank you, Stephen. Next, we're going to hear from Barbara Farrell. Barb, and we'll get your slides ready in a second.
Awesome, thanks very much. I'm really pleased to be able to speak today. I really enjoyed listening yesterday afternoon, and I'll just get started right away. If you want to move ahead to my next slide, please. So since 1999, I've been working in a geriatric day hospital, and I want to start my discussion by saying that yesterday we talked a lot about benzodiazepines in terms of abuse, dependence, especially with respect to concurrent use with opioids and other drugs of abuse. My clinical experience is different in that I'm dealing primarily with frail, older people who are struggling at home with cognitive impairment, falls, general frailty and weakness that's affecting their independence. So not typically people who are struggling with abuse or other dependence issues, although sometimes. So my role in the geriatric day hospital, which is an interprofessional team of healthcare providers, is to work with patients and the rest of the team to try to minimize different types of drug-related problems. And that's often through de-prescribing, reducing doses, or stopping of medication. So I'm going to speak primarily to that experience as a clinician, and also through my knowledge of the literature. And one thing I wanted to say, whether I was so thrilled to hear Yasenda Busto's name mentioned yesterday, because as an undergraduate and then a graduate student, she was one of my supervisors back in the 80s and early 90s. So I think a lot of my interest in this area stems from my work with her. So for the last 20 years, I've been working in this geriatric day hospital environment, and I have found that most of my patients have started using benzodiazepines for insomnia, often for grief, and then it was continued on for long periods, or during hospitalization. And different studies show that somewhere between 10 and 40% of people are started and continued on a chronic benzodiazepine from their hospitalization period. So these medications, as you know, are often intended for short term, but they're continued long term. And so it's not unusual for someone to say to me that was started, 15 years ago when my husband died, and then it's just continued. So the impact that we find in our patients is that often alone or in combination with other CNS depressants or anticholinergic medications, they have cognitive impairment, daytime fatigue and sedation. And I keep a little list of the kinds of things people say to me. It's so hard to get going in the morning. I have no energy. My friends are all still doing things together, but I can't concentrate. I must be getting old. And they often will describe a sort of a hangover effect that they have in the morning, and they seldom feel well rested when they wake up in the morning. In addition to that, we've got the falls and fractures risk of motor vehicle accidents, and all of these potential issues. You would think it would be easy to stop a medication that might be contributing to these problems, but it's not. And so I think a lot about why is it challenging to stop? And there's a number of reasons. First of all, most of my patients have tried to stop at one point, but the common refrain is, oh, that's the drug I never miss. I tried stopping once and I couldn't sleep, so I figured I needed to keep taking it. They also will say things like, well, it must be safe because my doctor keeps prescribing it. I keep getting refills. So there's this sense that it's a safe medication. And people often feel very defensive or targeted about this medication. We could go through a list of 16 medications and they'll chat about each one. And then we get to the Ativan and they'll say, oh, my doctor is always after me to stop that one. I don't even want to talk about it. So instead of talking about the medication, I usually start by talking about the reason they're taking it. And for the most part, this is sleep. So I try to understand more about their sleep history. It helps me understand what other factors might be contributing to problems with sleep, what other medications might be contributing, what's modifiable in terms of insomnia management, and their perception of the risk benefit of the benzodiazepine medication. And that really helps inform the next conversation, which is around shared decision making, as Stephen mentioned. So if we could go to the next slide, please. So following this discussion about why they're taking the medication, I typically ask when it was started, why it was started, what has been their experience with taking it, how well they think it's working, what happens if they miss a dose, the potential impact on the issues for which they're coming to the day hospital, such as weakness, daytime fatigue, falls, etc. Then we would talk a little bit more about how to make the decision about whether to continue with the medication or not. And this involves discussing both the risk and the benefit of continuing and the risk and benefit of stopping. So in terms of continuing with a benzodiazepine, we have all of the side effects we've talked about already: falls, fractures, daytime sedation, memory problems, respiratory exacerbations, cognitive impairment, motor vehicle accidents, etc. And I talk about the fact that even though they've been on it for 15 or 20 years, that with seemingly no problem, that they are in fact more vulnerable to side effects as they age for a variety of reasons. And in terms of potential benefit, again, I'll go over that we have these short-term studies that show you get to sleep 5 or 10 minutes faster. You may sleep 25 minutes longer, but these studies show that after a few weeks of use, that those effects go away, but that sleep architecture, so deep restful sleep, is not preserved when you're using a benzodiazepine, and that the other adverse effects remain. We also go over the risk and benefit of stopping the benzodiazepine, and I like to start with the benefit. So you might have fewer falls. We know from studies that if we stop a benzodiazepine, your thinking ability will improve. And there's a great study by Curran in 2003 that showed improved performance on a number of cognitive and psychomotor tests 6 months to a year after stopping benzodiazepine. So talking about what's the long-term beneficial impact. Your ability to remember information will likely improve. Your ability to mentally manipulate numbers will likely improve. So card playing might get easier. And this is sounds weird, but it's a common challenge in older people, that they have more trouble playing cards. And that's something they enjoy doing. And so they want to be able to do it again. They will be able to process information and react more quickly, which could have an impact on their ability to maintain their driver's license. In terms of, so all of those discussions help inform this shared decision-making discussion with the patient. The next step in shared decision-making is to discuss the different options, which could include a variety of tapering plans. And my first bullet there is, can you abruptly stop a benzodiazepine? Years ago, I would have said no, because I was quite convinced that everyone would have withdrawal reactions. But what I found working in the day hospital is that quite a few people actually do abruptly stop their low dose of Ativan or oxazepam that they've been taking. And this wasn't really purposeful, but I would talk about, the benefits, the risks, what potentially we could do, tell people, why don't you take a week or two to think about it? We'll talk about it again. And then when I follow up with them, they say, oh yeah, I stopped that, with seemingly no withdrawal at all. So I know that that's possible in some patients, The challenge is we don't know necessarily which patients that's going to be possible in. So typically we work together to develop a personalized tapering plan that's consistent with what doses are available with that medication. There is data to show that the longer you've been taking a benzodiazepine and the higher dose, the longer you will likely need for a tapering plan. One of the things that we do not do in our practice is switch to a long-acting benzodiazepine, and that's because we're concerned about potentially worse side effects in our older patients. And I have not been able to find studies that show that switching to a long half-life benzodiazepine in an older person alleviates withdrawal symptoms more than a slow taper of the medication that they're already on. There's also the concern when you switch to a long-acting agent, and I've seen this happen many times, is the patient continues on both the short-acting and the long-acting because the decision gets made to change, but there is no prescription written to stop the short-acting agent. And so that sometimes the patient continues on both inadvertently. In terms of monitoring, we monitor first for the positive benefits of stopping a benzodiazepine. And our patients, the fatigue, typically the daytime fatigue will typically improve within a week or two of making a dosage reduction in benzodiazepines, and people are really they're reinforced by that improvement, and cognitive tasks can take a little bit longer over say 6 months or so. The rebound insomnia, which is the most common withdrawal effect that we see in our practice, tends to occur within the first few days of the last part of the reduction or stopping of the benzodiazepine. And I find in general that people, when they understand that that is going to happen and they know the time frame within which it's going to happen, and they know that it will get better within a week to a few weeks, they are willing to commit to that. Most of the time, people have never been told that the rebound insomnia will eventually go away. And I'm not saying, and I know Stephen is talking about perhaps a different group of patients. I'm not saying that that happens for all patients, but in my frail elderly geriatric day hospital patients, that's what I tend to see. Anxiety as well can be there for a few days and typically also improves. So I check in with those patients every few days after a dosage reduction or a cessation. The other thing that I do is have people pick a start date or a stop date, really a start date for tapering and a stop date for stopping, similar to how they would choose a stop date for smoking cessation. And doing that actually has also allowed me to find out more about how people want to stop. So a lot of people would choose to stop on a weekend or on just before a few days when they don't have anything planned. I had one fellow tell me he was going to stop while he was away visiting someone because he'd be staying at a hotel and he always got a fantastic sleep at this hotel. So that led us to a discussion of the fact that he hadn't bought a new mattress, a new bed mattress for 20 years. And ultimately his intervention was buying a new mattress, and then he was able to stop his benzodiazepine. In terms of support, I would help them to identify and avoid substances that can worsen sleep. So different medications, caffeine, alcohol, salbutamol right before bedtime, albuterol in the US, the pseudoephedrine, anything stimulant is obviously going to cause insomnia or worsen anxiety. There are a lot of different guidelines, educational pamphlets, sleep hygiene approaches, CBTI approaches that I'm going to cover in the next few slides very quickly. But I find in general, the most important thing is to provide reassurance that withdrawal is temporary and manageable and accompanied by improved cognition, and to provide a time frame around when we expect to see those symptoms arise. So if we can go to the next slide. I just wanted to point out a number of resources. I was involved in a team that developed an evidence-based de-prescribing guideline for benzodiazepine receptor agonists, specifically when they were being used for insomnia. So this doesn't apply to other conditions where benzodiazepines are, potentially appropriately used. And those are listed in the inclusion criteria on the algorithm. So the algorithm is here on the left hand of the slide, the front and the back pages. There are sleep hygiene strategies, both for community dwelling folks and also for people living in residential care, highlighted there. This guideline is available open access in Canadian Family Physician. It is also part of an app that you can get through the IAM medical guidelines. The app is great because it links different parts of the algorithm, which you see on the left, to the content in the actual guideline and the references. On the bottom here, you see a patient pamphlet that we developed that essentially repeats the information in the guideline, but in a format that's a little bit more accessible to the public. And all of these are available on our website, de-prescribing.org. And I also wanted to point out this testimonial on our website. It's a short little 2-3 minute video with a patient who went through the process of benzodiazepine de-prescribed, and this particular lady had been taking it for some severe anxiety. And I think it took her about 6 months to stop the medication. But she talks about her experience, which can be very helpful to patients, to people who are new to the process and trying to understand what to expect. Next slide. We also have an infographic based on our algorithm that can be used as a poster in a pharmacy or a clinic office to alert people to discuss this medication with their with their prescriber. I also wanted to point out the Canadian De-Prescribing Network, which hosts a number of patient handouts developed by Dr. Cara Tannenbaum and her team in Montreal. You may have heard of the Empower guide, and this particular pamphlet has information about benzodiazepine myths around side effects of the medications, and then tapering strategies, including a pictorial representation of how medications might be tapered. And they've actually shown that by mailing this to patients, they can reduce benzodiazepine use in the community. I would also encourage you to check out this Sleep Well website, which was developed by Dr. David Gardner and Andrea Murphy in Halifax. And they have put together a lot of resources around cognitive behavioral therapy for insomnia as an approach to reducing benzodiazepine use. So I also share that website with patients as well. The Mayo Clinic has similar information available on CBTI. Next slide. And then also in Ontario and Canada, we have the Centre for Effective Practice, which has a number of different algorithms and educational pamphlets available around benzodiazepine use, a little bit more focused on alternatives. So for example, if someone has anxiety, what could that alternatively be treated with? So it's helpful from that perspective. And then recently, the Canadian Coalition for Seniors Mental Health developed a guideline around benzodiazepine use disorder in older adults. And of course, there's the Ashton Manual, which has useful information, particularly for people who are really struggling with benzodiazepine dependence. And I know I've talked a lot about a very specific population, which maybe doesn't have the severe dependence issues with the severe withdrawal that other people may have. But I find on occasion that this resource is helpful for people as well. And I think we'll go to my final slide now, which are my thoughts around avoiding chronic benzodiazepine use. And I think for me, it's important for prescribers to begin with the end in mind, always thinking that particularly for insomnia, mild anxiety, that benzodiazepine use is a temporary strategy. Maybe as short as 7 days, maybe a few weeks. Always use low doses, as Stephen said. Decide and talk about the exit plan upfront as soon as you prescribe. Prescribe small amounts. And this is important even at hospital discharge. There's probably not a need at hospital discharge to give someone 30 tablets of a sedative if they've only been using it to help them sleep in the hospital. So a few days to help them get sorted out at home, and that's it. and then look at non-pharmacological strategies, particularly in the hospital, around safe sleep protocols, education for staff and prescribers, both of which have been shown to reduce benzodiazepine chronic use, removing benzodiazepines from the admission order set, and again, limiting discharge quantities and providing a de-prescribing plan. And then just in thinking over the last day or so, and even listening to Stephen, I'm thinking about gaps in education and research. And I think, I do think we need more rigorous qualitative information about the experiences of people going through benzodiazepine tapering, and their preferences would be helpful, particularly in different groups, such as the frail elderly. I do think it would be valuable to study tapering protocols, because we don't really know which ones work best, and we don't know what the risk factors for withdrawal are. And now I'm even wondering, listening to some of the presentations yesterday and to Stephen as well, is there something different about the frail elderly group that they do not necessarily experience the severe withdrawal that other people do? Because that has not been what I have seen in 20 years of practice. So I'd be really interested to hear comments about that from the panelists later on. And I'll stop there, and I'll look forward to the discussion. Thank you.
Great, thank you, Barb. Next up is Sangeeta Tandon. Sangeeta? It looks like you may be muted, Sangeeta. You may have your microphone muted, Sangeeta. You're not muted on Zoom, but you may still be muted. Can others hear Sangeeta? Do you want? Not able to hear you yet. It may be a problem on my end, so let me. Oh, okay. So we just got confirmation that, yeah, it sounds like your microphone may not be working, Sangeeta. So we're going to ask you, we're going to try one more time, and then we may need to move on to our panelists, and we'll try to come back to you. I'm afraid the audio is still not working. So we're gonna move on, I think, to the panel, and in the meantime, we can try to do some troubleshooting offline. So with that, I know that folks are going to be eager to hear your thoughts and the thoughts from the FDA team, but and I hope we get to circle back to that. But we'll start with some panelist remarks, and then when we get you up and running again, Sangeeta, we'll jump right back over to you. But maybe for some initial reactions, Chinyere, would love to hear some of your initial thoughts.
Can you guys hear me okay? Okay.
Loud and clear.
All right. Yeah, so I thought the slides that were presented were really great, and I could think of a lot of patient experiences that I've had or interactions that I've had that really highlighted some of the points that were brought up. And I wanted to talk specifically about a more recent patient that I'm currently seeing. She's a woman that's in her 60s, and she actually was started on Ativan 1 milligram at bedtime for anxiety following the sudden death of her mother. So she had a panic attack. She saw her primary care doctor. They started her on Ativan. She was started on a lower dose, but then was bumped up to 1 milligram and kind of stayed there. And she had been on that dose pretty regularly and steadily for about 4 years. And then during that time, she had a number of different changes in her primary care provider. So she would see different people every couple of years. And each time that she would see someone, they'd say, oh, you're on Ativan, you're older. These are all the risks associated with being on benzodiazepines. We need to get you off right away. So she had this experience where she was seeing these providers. Everyone was basically telling her she shouldn't be on this medication, taking her off of it really quickly. And each time that happened, she would end up in the emergency room with a panic attack. So the time she came to me, I actually kind of got her and her whole family, who were very upset with the care that she was receiving. And she was really scared. She was scared to see a new provider, having had that experience before in the past of seeing multiple people and people just taking her off of this medication as quickly as possible and not really addressing any of her previous experiences. So the first thing I did was really just listen to her. I asked her, tell me how long you've been on this medication. What has the doses been like over the years? And what has your experience been like specifically with trying to come off of the medication? And I really just listened to her experiences with having increased anxiety, rebound anxiety, sleep difficulty, having to go to the emergency room, the fear and the anxiety that she really felt surrounding this medication and being on this medication, and really validating those experiences. And a lot of the things that she was describing in terms of her withdrawal were common things that we hear from our patients when they are experiencing benzodiazepine withdrawal. So I spent a lot of time just in that first visit, just listening, kind of hearing her story, validating her experience, that it is really challenging and it's really hard to come off of these medications that you've been on for a long period of time, and to try to do that in the course of a week or 2 weeks. And after hearing her experiences, we talked about what she could expect in terms of coming up with a taper plan, and a plan that she felt comfortable with, and a plan that she felt confident in as well. So we spent a lot of time talking about what to anticipate and going over some anticipatory guidance in regards to what the taper experience would be like, what the pacing would be like, what the taper steps would be like, how slowly we would go. And in each time going over all of these steps, getting feedback from her, and also trying to pull from her previous experience and highlighting the successes that she's had, as well as some of the failures that she's had. I really talked to her about ways that we could address any of the rebound anxiety that she may experience, or rebound disturbances in her sleep. We talked about ways that we could address it both pharmacologically with adjunct medications, as well as behavioral interventions that she could participate in. In Kaiser, we have sleep education classes, we have anxiety management classes, we have anxiety groups. So I talked to her about those options. We also have a partnership with the Calm app, where we have our members have the ability to download that app for free and utilize that app. And it has a lot of great resources on there in terms of sleep stories, guided meditation, daily calm, a lot of resources that the patient can use. They're literally in the palm of her hand to kind of help her manage anxiety if she were to experience it during the process. So I found that taking the time to review what the patient could expect, and also taking the time to review what the plan would be for her, and letting her know that there is flexibility in that plan, that if we reach a point where she feels like the withdrawal symptoms are too much for her at that time, that we could pause, we could stop. We didn't have to keep pushing through. There wasn't necessarily a timeline that we had discussed, but also letting her know that the ultimate goal was to help her come off of the medication. And so really fostering that rapport and fostering that partnership and collaboration, and coming up with a plan, giving her the information that she needed so that she felt confident and was able to build up some confidence and self-efficacy during that taper process. What was challenging certainly was COVID, and challenging for all of us, both patients and providers alike. And there was a point in time where she got a lot of anxiety, not necessarily related to the taper, but related to COVID, and related to vaccines, and being around her grandchildren, and just the fear that a lot of people had, and anxiety a lot of people had, specifically with COVID and the COVID precautions. And so at that time, we actually talked about just taking a break and just holding the dose that she was at for a little bit of time until she was able to get her vaccine. And just getting vaccinated was enough for her to feel more calm and to be able to continue with the taper. So every time that we checked in, it was, asking her how she was feeling, asking her what else is kind of going on in her life that may potentially be a barrier to her, or make it more challenging for her to be able to taper. And we have actually been able to reduce her dose. She's down to about 0.25 milligrams of Ativan at this time. So started at 1, and we've been able to get her down to about 0.25, and she's doing great. And so being able to provide patients that information ahead of time to kind of let them know what to expect, I think is a really important step when embarking on having that discussion with patients about tapering, and also collaborating with patients and helping them feel a sense of empowerment and a sense of self-efficacy and being able to engage in a taper and complete the taper. And those were a lot of the recommendations and a lot of the points that were highlighted in the presentations that we've heard earlier. And I thought that those were really spot on in terms of the experience that I've had working with patients to taper.
Thanks, Tina. And with that, I think we are going to try to turn back to Sangeeta and see if our technology is working for us now. Sangeeta, want to check your mic really quickly? I'm afraid we still can't hear you. This is frustrating. So maybe we can try some other options and return to you. Maybe move on to our next panelist. So next up we have, I believe. Hello, oh, we can hear you now. Oh, terrific. So
all right.
Yeah, let's get your slides queued up and we'll get you started. Just a moment.
Great.
All right.
Thank you so much, Adam. You have to love the virtual environment, right? So good afternoon, everybody. My name is Sangeeta Tandon. I'm a pharmacist staff member of the Professional Affairs and Stakeholder Engagement, also known as PACE, within the Office of the Center Director in the Center for Drug Evaluation and Research. Today, I will give you an overview of PACE and help you understand some of the outreaches that we do and continue to do to highlight FDA's commitment to stakeholder engagement. Next slide, please. As a disclaimer, this presentation reflects the views of myself and should not be construed to represent FDA's views or policies. Next slide, please. So today's objectives are, we're going to discuss the role of PACE. We're going to discuss two of the program's network of experts and safe use initiative. We'll discuss some of the expert opinions regarding benzodiazepine prescribing practices. And then finally, we'll discuss some of the research funding opportunities that are available through the FDA through our office. So you may be wondering, what is PACE's function? So PACE promotes a culture of engagement within CDER by facilitating the exchange of information between CDER offices, divisions, and external stakeholder groups. PACE supports CDER by facilitating communication and strategic engagement with external patient groups and professional healthcare organizations, as well as some state and federal entities, amongst others. So you can see here on the right-hand side, we have non-regulatory external stakeholders. So some examples of that are some patient advocacy groups. We've facilitated exchanges with the ALS Association. We've worked with state regulatory boards. That could be the National Association of Boards of Pharmacy, Federation of State Medical Boards, some healthcare provider organizations such as the American Heart Association, American Academy of Pediatrics, some patient safety groups. We've worked with ISMP, or Institute of Safe Medication Practices. We've had researchers in harm reduction. We heard one speak yesterday from the Rocky Mountain Poison and Drug Safety Group. And we have federal partners as well, such as AHRQ, or the Agency for Healthcare Research and Quality. So our mission is really to enrich the experience of patients, advocacy groups, healthcare professionals by engaging with CDER. We want to improve our stakeholders' drug regulatory insight and understanding. And then finally, we want to enhance the safe use of medications and reduce preventable harm from medication misuse, abuse, and error. One of the ways that we do this, the ways we promote culture of exchange within CDER and how we facilitate exchange of information between CDER offices and external stakeholder groups, is through network of experts. Sometimes we call this NOE. NOE is a way we facilitate collaborations and exchanges between CDER scientists and experts associated with external organizations. So this is really a group of vetted network of partner organizations and their member scientists, clinicians, or engineers. NOE is a mechanism to provide FDA access to expertise to supplement existing knowledge and expertise. It gives us real world experience or insight about a clinical activity We're not asking about regulatory questions or asking about regulatory decisions. So it's really not a replacement for existing mechanisms for obtaining external scientific or clinical expertise, such as an advisory committee. Next slide, please. So some of the areas that we asked for feedback from the experts were in regards to approaches to prescribing benzodiazepines. We wanted to understand clinical guidelines or support tools that are currently available for decision-making. We wanted to see what education and resources were available both to the experts and their patients. We were curious to see the pandemic effects on decision-making about prescribing practices for this class of drugs. And then finally, we were interested in seeing the awareness of the safety labeling change and drug safety communication that was issued in September of 2020. Next slide, please. PACE reached out to a wide variety of organizations representing specialties that prescribe benzodiazepines most frequently. So the 4 experts volunteered to speak was from December 2020 to March 2021. 3 of them were geriatricians and 1 was a psychiatrist with a subspecialty in addiction medicine. And we'll discuss some of the topics that we were covered, some of the themes that were identified, and some insights by the NOE experts. Here's some of the themes that were identified through the calls. All experts expressed limited use of benzodiazepines in their practice and often avoiding benzodiazepines if possible. There was little to no distinction between the benzodiazepines compared to the Z-hypnotics from a risk perspective. So what we're talking about here is ways that the experts described the risk, and that was that they had the same neurocognitive impairment for these types of drugs, or it was described as having similar risk for developing tolerance and experiencing withdrawal when stopping. So that they had little to no distinction between these types of drugs. And the overall consensus is that there's no evidence-based guidelines for tapering benzodiazepines. So tools for negotiating a benzodiazepine taper are often lacking. 3 out of the 4 prescribers identified educational tools for their primary care physician peers as an area of need. And there was concerns about initiating benzodiazepines inappropriately or in a suboptimal way. So oftentimes with these experts, patients had already been with their primary care physicians prior to this. So they already saw patients on this for years, maybe decades before they came to these specialists. So there were concerns that there may be initiation of these class of drugs inappropriately. As far as the themes identified, one of the questions that we had asked all the experts is whether COVID-19 affected decision-making about or prescribing practices for benzodiazepines. And here's some of the thoughts that we heard. One of the experts said there was an enormous spike in phone calls and requests and people begging us for medications to help calm anxious ones. In general, the threshold to prescribe these medications was much lower, and there was this hesitancy to de-prescribe medications in a virtual environment. There was hesitancy because there was many experts expressed difficulties doing so over the phone, and that the trust and the relationship was different in a virtual environment. Older patients tended to get off the phone more quickly than if they had been in a clinic. Other experts stated that their patients felt that they had less privacy in their home when they were on the phone versus in the clinic, and there was less, time and emotional space for them to have those sometimes difficult conversations. And then as far as the themes identified for the awareness of the safety labeling change. So the safety labeling change happened in September 2020, and that was the box warning was updated to include the risks of abuse, misuse, addiction, physical dependence, and withdrawal reactions to help improve their safe use. So we asked experts their awareness of the safety labeling change that happened in September 2020. And in general, experts reported either being unaware or having limited recall of the safety labeling change. One expert was unaware, and she followed up with her team to see if they were also aware. And so she cited that 8 of her prescriber colleagues were unaware of this change as well, She had surveyed 6 of her practicing physicians. She had surveyed 6 other prescribers and 2 nurse practitioners in her clinic, and no one knew of the warning. And she also mentioned that she had talked to a pharmacist and a nurse, and no one had been aware of the messages as well. And she does recognize this is an unscientific poll, and she may have missed a wide range of people, but she asked us to follow up and ask and see how her message was delivered, and we'll go over that in the next slide. And 3 out of the 4 were aware. However, 2 of those could not recall the content or the wording of the safety communication. And all of the experts that did say they were aware, they identified themselves as being cautious or tight in prescribing practices already. And so as far as the question is of how was the information disseminated, so the drug safety communication was and the associated press release, which was supportive of the drug safety communication, was issued on September 2020. We had messages go through listservs, and we also had communication go out through social media. Next slide, please. As you can see, the experts who spoke with FDA shared important insights, which reinforced CDER's interest in stakeholder engagement regarding benzodiazepines. And today's workshop is an example of this ongoing effort. Here's a summary of insights that were expressed in our NOE from our NOE expert calls. Prescribers identified a need for evidence-based tools for tapering benzodiazepines. The pandemic impacted prescribing patterns for benzodiazepines. There's little to no distinction made between this class of drugs and the Z hypnotics from a risk perspective. And there was an identified need for resources for their primary care physician colleagues, especially on initiation for these benzodiazepines. And then one expert identified that neither her nor her peers were aware of the safety labeling change. So that really begs the question, are there additional ways to disseminate labeling changes to prescribers? And this is a nice segue into our safe use initiative discussion. So another way of promoting culture of exchange within CDER is through our safe use initiative program. And this is a way that we solicit and fund research projects that align with the mission and goal of reducing preventable harm. In yesterday's discussion, there were many unanswered research questions about understanding benzodiazepines as a class of drugs. And specifically, there was discussion about proper disposal of benzodiazepines to prevent risks, understanding prescribing patterns better, understanding who the populations that are using benzodiazepines. There was discussion about stratifying certain populations based on populations by risk. So if you do have an idea on a research topic in this area, reach out to us. The Safe Use Initiative, the goal is to reduce preventable harm, and this could be through identifying specific preventable medication risks and developing, implementing, and evaluating cross-sector interventions with partners who are committed to safe medication use. Next slide, please. And to give you an idea, Safe Use Initiative, we have 8 current projects, and we have funded 26 projects involving a wide variety of drugs and potential adverse events, and some that are always on the top of the list for high adverse events. You can see here the opioids, anticoagulants, anti-hyperglycemic agents, but we also fund a wide variety of other classes and types of drugs, so antibiotics, NSAIDs, stimulants, and you can see on the below there's a link so you can see the entire list of different research proposals that we have funded. Safe Use Initiative, we welcome the opportunity to have a conversation about research ideas and project concepts. A unique advantage of this program is that you can actually contact us before you write us or submit a written proposal. And as you can see on the left-hand side here, we have partnered with healthcare professionals, hospitals, patients, caregivers, and their representative organizations, and a wide variety of stakeholders. And we really reiterate our commitment to being a resource to you. I have the email address here on the bottom right-hand side. I hope this helps you understand some of the outreaches that PACE does and continues to do to highlight FDA's commitment to stakeholder engagement.
Great.
And on the next slide,
oh, sorry, so go ahead. Sorry.
and the next slide, I have my email address here in case anyone has any questions. but I'll go ahead and turn it back to you. Thank you.
Great. I'm really glad we're able to get your microphone working and some really useful information on PACE and on the safe use initiatives. Thanks for sharing all that. And I'm sure we'll come back to some of these issues in the discussion too. So I'm going to pick back up where we were and going through some of our discussants' comments for this session. And next up is Sumit Agarwal. Sumit?
Great. Thank you to Duke and FDA for wading into this issue. A couple of years ago, my co-author and I published a study in JAMA Network to look at the landscape of benzodiazepine prescribing. You know, it's such a large class of medications prescribed by so many different types of physicians for so many different indications. And so we wanted to know, how are these medications being prescribed, for what reasons, and by whom? And we used national survey data from the CDC. And we had several important findings. The first was that, you know, benzodiazepines are increasingly being prescribed and co-prescribed with other sedating medications. It's why we're all here. You know, we found it doubled from about 3.5% of visits to over 7% of visits from 2003 to 2015, which is pretty much lock in step with the rise we've seen in overdose deaths involving benzodiazepines. And I think it's important to point out that it's long-term prescriptions, not short-term ones, that drove this increase. In some ways, I'd be less concerned if it was, you know, limited one-time prescriptions, but that's not the case. It's people who are getting started on benzodiazepines and then they stay on it long-term. There's another study published earlier this year that looked at benzodiazepines prescribed perioperatively, so right before surgery or right after surgery. And benzodiazepines were prescribed in about 3% of surgeries to people who have never had exposure to a benzodiazepine before. And then a fifth of them, 20%, were still on benzodiazepines months later. So it just reinforces it's easy to start, but hard to stop. The second thing we did in our study is we took a look at what prescribing was doing by specialty and indication. And we found that prescribing was actually pretty constant among psychiatrists and had really risen among primary care physicians, who as a group accounted for about half of benzodiazepine visits. And then looking at it by indication, you know, prescribing didn't change much for insomnia, and increased a little bit for anxiety and things like seizures, and it increased quite a bit for back and chronic pain, an indication, you know, for which there isn't great evidence for their use. You know, so those are, you know, a couple of our major findings that I hope will help inform how we can move forward with this large class of medications. And I'll add a comment as a, you know, primary care physician who takes care of patients and prescribes benzodiazepines, and partially in reaction to some of the comments we've already heard. You know, I really approach prescribing and discontinuing benzodiazepines very differently. You know, they're often not the same patient. There's one set of patients who I'm considering, you know, starting a very limited prescription. And then there's another set of patients who I inherit or come to me and they've been on benzodiazepines for, you know, a long time, on high and sometimes multiple doses a day. And these two scenarios are very different. You know, for the first, you have some room to discuss risks and benefits of starting the medication. You know, you can discuss and nudge them towards alternatives, and then you can set expectations up front about how much you're going to prescribe. And then for the second, it's more of a delicate negotiation to get them to buy into tapering, and then to do it slowly over a long time period, like Stephen talked about. You know, same drug, but very different opportunities and challenges when it comes to prescribing versus de-prescribing. So thanks for having me. I look forward to the Q&A.
Great. Thanks very much, Sumit. And next is Christy Huff.
Hi, everybody. Thanks for having me here. I am a cardiologist and I am director of Benzodiazepine Information Coalition. And I'm here today as a patient advocate. And particularly, I want you to hear the patient voice today, because I think that's what's often missing from the benzodiazepine safety conversation. In 2018, I helped develop an online survey to capture the patient experience with benzodiazepines, particularly their withdrawal. And, you know, most of the patients in our population are experiencing physical dependence and withdrawal effects and not necessarily addiction. But we had over 1,700 respondents, mainly from the online benzodiazepine support groups. Results are not yet published, but I would like to share a handful of the comments that we received from benzodiazepine survivors. I believe they are powerful. If I could think of the one worst possible thing you could do to a person, it would be benzo withdrawal. It beats cancer and Alzheimer's combined. It is important that we be believed when we report how horrific the symptoms are that we have experienced, and they can go on for many, many years. One of the most brutal aspects to my withdrawal experience is that I was not believed and even laughed at. I was constantly coming down with mystery illnesses from the drug, and these illnesses required additional medications to cover up the problems. Doctors never once acknowledged the pills could be the reason behind any of my issues. After 30 months of not taking benzodiazepines, one 10-year user said, "I'm still so violently ill, I'm bedridden most days with symptoms." And lastly, benzos have completely destroyed my life. Existence is beyond torture. I do not believe I will survive. While these comments are certainly shocking, I know that these patients are not exaggerating because I've had the same experience. In 2015, I was harmed by benzodiazepines. The words that describe my experience don't exist in the English language. Suffice to say, it was a torture beyond all imagination. And the worst thing is it went on for years. I don't have time today to tell you my full story, but I'll describe it in a nutshell. I developed physical dependence and severe interdose withdrawal simply from taking short-term low-dose alprazolam exactly as prescribed by my doctor. I switched over to diazepam to taper, and it took me over 3 years to come off. That was as fast as I was able to taper off the medication. During that time, I experienced multiple horrific withdrawal symptoms. I was completely disabled, unable to work or care for my child. Fortunately, my story ends well. I finished my taper. I'm now over 2 years benzodiazepine free. And while much better than I was during my taper days, I still do suffer symptoms of protracted benzodiazepine withdrawal. When my problems began with benzodiazepines, what was shocking to me is that I had difficulty finding a doctor to help me. The most help that I found with benzodiazepines was actually on the online support groups. There I met many other patients who had suffered effects from taking their medication simply as prescribed, yet they were still having adverse effects and prolonged and difficult withdrawals. These patients were turning to online support groups because they were having difficulty, like me, finding a doctor to diagnose and treat their problems. And is unfortunately, many times their only option for help and support. As I read more about the issues surrounding benzodiazepines, I was struck by the lack of training that I had received during both my medical school and my internal medicine residency, particularly about the length and severity of the benzodiazepine withdrawal syndrome and how to properly de-prescribe a benzodiazepine. And as I talked with other patients on the forums, it became clear to me there's a general lack of knowledge in the medical community surrounding these drugs. And it's one of the main reasons I became involved in advocacy. So I just listed here on this slide some of the gaps that I perceive there to be in physician education. This is based on feedback that we receive quite frequently from patients that have been going through benzodiazepine withdrawal. But one of the major things is people are being taken off benzodiazepines either abruptly or tapered too quickly by their doctor. I'll just reiterate the need for a flexible, gradual taper plan for patients. Not everyone needs to take a long time to taper, but some patients are going to need months or years, like in my case. Often physicians are not recognizing the adverse effects, including tolerance, physical dependence, and withdrawal. And there's an overwhelming lack of informed consent, which is why I actually wrote that informed consent form that Steve had mentioned to you earlier. And lastly, there's little awareness of the protracted withdrawal syndrome. I will say I was very excited to see in the recent drug safety communication about the existence of protracted withdrawal syndrome. Next slide, please. Because up until now, patients, when they ever experienced it, have not been believed. Steve actually coined the term benzodiazepine injury syndrome, which I think is an apt description because these symptoms are going on for years, and I think it's probably beyond what we would expect from withdrawal. I think these patients have experienced some type of neurological injury. Ashton's work describes about 10 to 15% of people experiencing a protracted course. And really, I just think it's the relentless nature of these symptoms plus lack of support and treatment increases risk of suicide in this population. So I'll just conclude by saying that I think the benzodiazepine injury syndrome or protracted withdrawal needs a lot more research. This is definitely a gap in our education. We need to know numbers affected, who is at risk, and how to treat and how we can support these patients as well. Again, thanks for having me here today.
Chrissy, thanks very much for sharing your experience and for the work that you're doing at the Coalition. We really appreciate having the perspective today. Next, I'd like to turn to Scott Winicky.
Yeah, I wanted to make a few comments related to Sangeeta's presentation. So we talked to 4 different experts, and I think we heard some similar things from each of them or from the majority of them, that there's a need for resources in primary care, and I think Christy just alluded to that as well. That prescribers need evidence-based tools for tapering, that the pandemic really impacted prescribing and perhaps a hesitancy to taper or discontinue because patients are under additional stress at this point, and it is difficult. I think we all find it challenging to make the same sort of connection in a virtual environment as opposed to face-to-face. And also, she alluded to the idea that perhaps awareness among prescribers of the labeling change was suboptimal. And since I run the safe use program at FDA, I was thinking about how this we sometimes see some similar themes in the patient safety literature or that's reiterated when we talk to primary care physicians. And I certainly think the challenge for primary care is very difficult, right? They're seeing a high volume of patients with generally a few minutes per patient encounter. And that's really, really challenging because there are easy ways to cut corners, but to do it right, to do something like informed consent, to have a reasonable discussion of risk and benefits, there's no way to do that without taking time. And that can be challenging. There are pressures here, right? Because you have other patients in the waiting room who need to be seen. Or maybe you're trying to make it out of the office to your kid's basketball game or something. There are always other pressures, and I think to remember that primary care physicians are humans being asked to do a superhuman job. I think another thing to remember is that acute issues tend to take precedence over chronic ones or subacute issues. So somebody comes in with anxiety or insomnia, that's the reason for their visit. We're all geared to mentally address that issue. And sometimes it's easy not to see, or it's hard to see the big picture, right? You want to do something to help this patient. And maybe the best answer is therapy, but that's not an easy answer to explain to the patient. It's also perhaps time consuming or challenging or expensive for the patient as well. So sometimes the easiest solution isn't maybe the best one, but it's a go-to. And then once you start a medication, I think Samit alluded to this, once you start it, stopping it sometimes is difficult. If you didn't enter in with an exit strategy in mind, if you didn't talk about it being used for a short term in the first place, then it just sort of gets added to the medication list, and sometimes it continues to be prescribed over time. And that's where we get into this chronic and difficult situation that I think so many have alluded to. So taking a step back and addressing chronic issues, right, can be difficult. It's hard to take the time for that. And also people are sometimes just resistant to change, right? If they're doing well, if what they're doing is working for them, or if you've tried to taper and they've had some rebound symptoms, they're often resistant to that. And that can be overcome. But again, that takes trust in the physician or the prescriber, and it takes time. And I was just going to throw in a plug for med reconciliation. So often we see, especially with transitions of care, medications are added or dropped off, and maybe it's not clear why a patient is on a medication or if they should be continuing it. And taking the time to stop and addressing that is really important. And particularly in older or medically complex patients, you get into the polypharmacy situation where you're increasing the risk of drug-drug interactions and adverse events, and you're making an already complicated picture more complicated. And then lastly, thinking about the labeling issue, getting information to prescribers is really challenging. They have limited time to seek information, and we have many, many, many sources of information. So they have to sort of pick and choose which to use and which to ignore. So one of the keys with, I think, getting information to prescribers and getting that information actually, to their eyes and digested involves sending it out in a way that they'll see it, or from a source that they trust or are likely to use. And I think that's just really challenging. I did primary care for 12 years, and you just don't have a whole lot of time to go and read. So you have to really be selective in the sources of information. I think all of those tie into the challenge of benzodiazepine prescribing.
Okay. Thanks very much, Scott. Really appreciate those perspectives, and also want to thank those of you who are participating today who sent in some questions. We've handled a few of those already. Kudos to Barb and others who are sending out via chat. A number of resources are available in support of these topics. We are working on a way to compile those too for their availability after the meeting. But I'd like to pick up with a few topics that we prepped the panel, or at least let the panel know we were going to come back to at the end of this session, starting with more on how health professionals are currently approaching prescribing, tapering, discontinuing benzodiazepines, and assessing risk of abuse, physical dependence, withdrawal reaction, so forth in that context. So we've had a lot of discussion on this already. I wanted to see if, going back to all of you, if there are any points that you'd like to add, things that you heard that you'd like to expand on or complement. And in particular, as we're thinking about steps related to prescribing, tapering, and discontinuing, how are non-pharmacologic treatments being used in conjunction with benzodiazepines or as alternatives? We had some discussion of tools that are being used yesterday and today, CBT, et cetera. But as Scott pointed out, it's often can be challenging for the physician who's time constrained, and both in terms of seeing patients and keeping up with the resources and research and guidelines that are available, and challenging for patients who have lots going on in their lives and financial constraints as well to follow through on some of these. So I'd like to just open up to the panel for further comments before we move on about the current status of how health professionals are approaching these risks and what some of the best opportunities, including maybe non-pharmacologic treatments, are to augmenting those efforts.
I can speak briefly about some work that's going on in Ontario. We have an interprofessional primary care model called family health teams, where there are physicians, pharmacists, social workers, different healthcare professionals working in a primary care practice. So we have about 170 pharmacists embedded in these teams across the province. And over the last year, a lot of those pharmacists and some of the other clinicians have been participating in training to be certified in delivering cognitive behavioral therapy for insomnia. And they've developed benzodiazepine de-prescribing programs, which they employ with individual patients or small groups of patients. So I know that that's going on. I know a lot of people are being trained and are trying to deliver the service, but I don't have any information about how many or how effective, but I do know that that's happening.
Great, thank you. Other thoughts?
Sure, I can go ahead and comment on this. So, I grew up in the universe where physicians we were the guy. We were the ones who made all the decisions and did all these things. But what I found in particular is that physicians are not the center of the universe, and indeed we need to use others effectively where our expertise is not there. Patients have their expertise with regards to their lived experience in that regard. Pharmacists have their expertise. Behavioral health has their expertise. For us older physicians, we've been trained the model of doing this our own. And indeed, it really is a team-based process, and to pull that together. And I want to emphasize the importance of preparation before making the steps into the tapering process. Support for the patient, development of the team, informed consent about all of the de-prescribing pathways, and the understanding too that prescribers need to have that the challenges could be covert in the sense that it's not obvious that my cognitive abilities and my psychomotor abilities are limited. I might be attributing that to my aging process and things like that. But an offer that actually includes, we don't know that it is understand until that tapering occurs. The challenge comes is that with initiation of tapering, things may get worse before they get better, and to allow for patience in the middle of all of that.
Great. Thanks, Stephen. And I appreciate your point. We've heard from several perspectives today on how much team support and team approaches to these efforts can really make a difference. I know that's not evenly available in United States medical practice. Other comments?
I would just say that educating primary doctors is so important. I mean, just based on the training that I received, I think we were pretty solid on the prescribing side of things. I knew not to prescribe them, more than a couple of weeks. And I knew about the risk of addiction, but we were never taught anything about physical dependence or withdrawal reactions or how to do a proper taper off of the medication. So I think that's a huge knowledge gap area right there.
Yeah, and maybe if we could stick with that a little bit too. If you all have other comments on this general topic of what's needed for what's going on in actual prescribing, what's needing to improve it, please add those in. But I did want to get in a couple of audience questions related to exactly what you were talking about, Christy, the limited availability of at least practical knowledge and the ability to apply it on de-prescribing. So one of the Q&As was specifically about experiences that you all have had with opportunities to de-prescribe benzodiazepines during transitions in care. So we heard from several of you, Sumit and others, about how many prescriptions start in an acute setting and patients undergoing procedures like who haven't used benzodiazepines before. They're involved in transitions in care out of the hospital, out of the acute specialist setting. Are there ways to improve the acute care, primary care coordination in that context, and ways to perhaps advance non-medical approaches to supporting these patients? Also, a question about I think a lot of recognition in the audience of the importance of more personalized tapering strategies. But one question, have any panelists encountered patients who are adamantly opposed to a taper, and is there guidance in that context? So just some further questions around this very important topic that Christy came back to around sort of the limited effective clinical experience and practices around de-prescribing.
Yeah, maybe I'll tackle that last one. Patients who are adamantly against tapering when they come to a physician, and that is a barrier. Patients are either pre-contemplative, they don't want to entertain it, they don't see it as a problem, or they're receptive but on the fence because they've had a bad experience de-escalating, or they know how miserable they'll feel, like Barb was talking about. And so I think the key there is that establishing a trusting longitudinal therapeutic relationship with the patient is the way you're going to get to that patient. And it might not be you eventually who starts that taper, but if they hear it the third, fourth, fifth time from another provider, they may start to think that it is a problem, and they'll start engaging with the taper process. And then once you start it, then it's about going slow and negotiating with the patient with the schedule that they're comfortable with.
All right, thanks, Sumit. And if I could say with you, just given how your practice works, you're in an academic medical center, you're working with a number of specialists too. Could you comment on how you think your center's activities are doing with respect to acute use of benzodiazepines for some of the procedures or short-term acute exacerbations of health problems? Is that appropriate? Is there good handoffs in place, either from the experience of the Brigham or more generally from your research?
Yeah, I think transitions in even in a coordinated academic medical center where we can easily contact our specialists remains an issue. transitions between specialists and primary care physicians, transitions between acute care and outpatient, acute care in the hospital and outpatient care. It remains a challenge. I had one experience, I turned to my psychiatry colleagues to discuss how to taper patients off benzodiazepines, and turns out they don't have much experience with it either. And so, the place where primary care physicians turns, which are specialists when they don't know how to handle something, wasn't there either. And so, for example, I got a recommendation to reduce the dose of benzodiazepines, but replace it with buspirone or hydroxyzine. And, I don't know the evidence behind it, but it wasn't successful anecdotally, but something to consider.
Any other thoughts on these issues around de-prescribing?
I think transitions are always a challenging time, and we're working on funding a research project right now looking at exactly that, trying to increase the coordination between the inpatient and outpatient setting, and to see if that can help, for instance, reduce hospital readmission. But I think anytime you have a change in provider, that communication is even with electronic exchange of information becomes very, very difficult.
Thanks. Let me ask another follow-up related to topics that came up yesterday in this context around prescribing behavior and patient perspectives on this. We had a lot of discussion yesterday about differences within benzodiazepines as a class, with a lot of the focus on alprazolam. Alprazolam hasn't come up much in this session today. I wonder if you all have any comments about whether there are different issues there relating to the topics we've discussed about current prescribing and ways to potentially make it safer and more effective. I would also like to ask about follow-up on lorazepam, where you all did have some extensive discussion in this session, seeming that Ativan may be different than others. So any comments about differences in benzodiazepines within the class from the standpoint of the prescribing issues and how to address them that we've been talking about in this session?
I would say from my personal experience, alprazolam has the issue of the very short half-life and the very high potency. And I developed very severe interdose withdrawal, and I could not taper it directly. So I ended up switching over to diazepam to taper off. But with that being said, from what we're seeing on the advocacy side of things, all benzodiazepines carry issues with physical dependence and withdrawal.
Thank you.
And I was just going to comment. I was just going to comment that we don't see much alprazolam used in my practice. In Canada, our data shows that lorazepam and oxazepam are the most commonly used benzodiazepines in older people. So I found the discussion yesterday really fascinating. I've always personally sort of felt negatively towards alprazolam just because of some of the early studies with Rickles and Schweitzer suggesting that, alprazolam might be more likely to be associated with withdrawal seizures, which haven't necessarily been shown with other benzodiazepines as much. So it's not something I've really felt strongly about using.
I think that what we see in the physiologic dependence realm is different than the addiction realm in terms of salience, as we call it in addiction, for substances. And that is a particular challenge there. But with short-acting drugs, we often see that a transition to a long-acting agent can be useful. So it certainly can be the case that you can taper off of the originally prescribed benzodiazepine. Sometimes that transition needs to take place. However, there can be new side effects when you make that transition to a long-acting benzodiazepine. It's not uncommon to see that switch to diazepam can result in increased sedation for individuals. So it's diazepam, clonazepam, and then phenobarbital, which has unique challenges in that. And don't forget, there are other adjunctive medications that have been tried in the withdrawal space. Carbamazepine, valproic acid, gabapentin may all have utility, but they also need to be tapered off. One of the most unique agents out there that I believe needs to be explored further is flumazenil. which is described as an antagonist, is probably better described as a very weak partial agonist. And it seems to, in this particular population, reset the GABA receptor to a more normal position. But this really emphasizes the importance of doing basic neurophysiologic studies on all of this. It's not just the GABA receptor that neuro readapts in this process. It's the glutamate receptors, NMDA and AMPA, as well as adenosine, and then the identified peripheral benzodiazepine receptor, which was identified and cloned in 1992, called the transporter protein, or the tryptophan-rich sensory protein. It was a kind of unknown to us in the benzodiazepine world because the different name, but it's highly relevant. It's on the outer membrane of the of mitochondria everywhere peripherally, and may be explanatory for the striking physical responses that we see that don't seem to be otherwise connected to GABA receptor, and validates the experience of benzodiazepine survivors speaking to these hypersensitivity more.
Yeah, and interesting. Having a little bit of trouble hearing you there, Stephen, but we got I think we got the main points. Any other comments on this topic about differential impacts across the different drugs in the benzodiazepine class?
Yeah, so I primarily practice addiction medicine and psychiatry here at Kaiser, and I can say that most of the times when patients are coming in and it's more of an addiction issue related to benzodiazepines, I am seeing Xanax. I'm seeing very high doses of Xanax, mostly due to that reinforcing effect and the short-acting effect. So oftentimes I'm seeing patients on Xanax 6 to 10 milligrams a day, which presents its own challenges and safely tapering those patients. When it comes to patients that are referred to me, and oftentimes primary care providers are referring patients to our addiction medicine department with concern about addiction, which ultimately really ends up being physiological dependence. It's more likely, Ativan or clonazepam or one of the other more longer acting. So you do kind of tend to see different benzodiazepines in different populations.
Great. Thank you. One, as Scott mentioned, FDA is providing, and as we heard from our panelists too, FDA is providing some research support for further understanding differential effects across benzodiazepines and maybe in responses too. Does anyone have any comments on what are the most important outcomes to measure there? What should be the focus of that research? You heard an overview of some of the research already during the session, and you're familiar with lots of it.
I think it's really important to catalog all the symptoms that do develop over time. What we find in the older studies that look at withdrawal symptoms, and you can actually see this in the labeling. When I look at the labeling, I actually look for is there a catalog of side effects that includes upper respiratory symptoms. The reason is that means everything was cataloged. If you look at the prescribed information for the benzodiazepines, they don't include that. And indeed, I would argue that the previous studies discounted symptoms that arrived that seem to be off target with regards to the GABA receptor, and discounted those. And indeed, they really are part and parcel of the withdrawal experience that a lot of individuals have. So I think it's really, really important to have a full catalog of symptoms, and then later do an analysis to see about a relationship to benzodiazepine withdrawal or not.
Yeah, and it as a great point. Does seem like a challenge, though, given the diversity of symptoms and responses that you've described.
Yeah, I think another challenge would be trying to look at that in different populations. So people taking the medications for different reasons, comorbid conditions, age, frailty, to understand is there a difference and what are the risk factors for severe withdrawal?
The question came up in the Q&A, really good question. How do you tell the difference between benzodiazepine withdrawal versus a relapse to the original condition that individuals are experiencing. And that is very, very difficult. And I would suggest that the way to look at that is that if there's a combination between a psychological symptom and a physical symptom, certain physical symptoms in particular, like hypersensitivity, sound, taste, touch, smell, those are all, when you see that combination between a psychological reaction and a physical or somatic symptom, that's most likely to be related to withdrawal rather than a relapse or rebound with regards to the primary condition that individuals are having. Also, the concept of waves and windows, the typical withdrawal pattern for other substances within the addiction-prone category is a slow decline over time, maybe a post-acute withdrawal part, but basically it's a continuous decline. What we see for benzodiazepines may be a decline and then a reactivation that occurs, and then the waves and windows on top of that that seem to be mysterious are actually not prompted by environmental cues or stressors, allostatic load as we call it, but are very much connected to benzodiazepines. So recognition that the pattern is different and the symptom array is different.
Great, thank you. Just looking at the clock, we are running short on time in this panel. This is a really good discussion. If you all don't mind, we might extend just a few minutes. I did want to get to some of the other discussion topics that we wanted to cover. While you've covered these partially already, I did want to come back to the issue of ways to improve prescribing practices, how to provide better support for health professionals and their patients. Now, you all have touched on a number of approaches to this already, including some of the guidelines that have been issued and the like. We did get a couple of questions about whether further guidance or more practical guidance or tools for primary care physicians, especially around tapering, would be helpful. A question about whether manufacturer alternative formulations could help with supporting tapering, smaller doses, et cetera. Any ideas that you'd like to add for ways to improve the supports available for patients and their physicians around safe prescribing practices?
I just popped into the panelist chat that can be distributed, the summary from the systematic review we did on the benzodiazepine de-prescribing trials. And it's interesting because the different trials have used relatively fast tapering methods, sort of 25% in the first week or two, compared to what we're talking about here. And so the recommendation in our guideline is based on that and is therefore faster than what some people might think would be appropriate. So I think it's useful to look at that, and we've created some tools to go along with that. And then the other patient education material that I'm aware of are those Empower brochures on the Canadian De-Prescribing Network website, and I've included that in the pop-up as well.
Yeah, thank you.
I could comment, 25% may work for a subset of individuals, certainly, but when you look at the population of affected individuals in the online communities, and there's actually only one published study that looks at that. Alison Fixon of the UK took a look at that. Christy Huff has alluded to a survey that we're trying to complete and publish in relation to that. If you look at that population, you can see that particular rate for that cohort of individuals is far too fast, and that leads to the recommendation of less than 5% initially, then to be enlarged on that if it's easy, or even reduced from that particular level as well. There are a variety of strategies out there called micro-tapering and liquid reductions. These are all off-label processes that certainly need to be explored, but have been effective for patients.
So would you recommend, or maybe there's somebody around the table who has some experience working with a compounding pharmacy to make smaller tapering amounts?
compounding possibly works. However, compounding benzodiazepines is really difficult. It's difficult to solubilize for these particular agents. And so I do recommend a good relationship with a pharmacist as part of the team, hopefully a compounding pharmacist. One of the options out there that I have found to be particularly useful is diazepam in a liquid solution, 2 milligrams per 2 cc's. And that can be reduced incrementally far easier than, say clonazepam. But individuals do a dry, cut and hold method where they actually chip away, use a joule scale to reduce the amount of, say, clonazepam or alprazolam, and they measure on a daily basis or periodically and make a reduction in relation to that. Christy, you might want to comment on that.
Yes, as far as compounding, we've had people use that method successfully. You just really have to make sure that you're using a trustworthy compounding pharmacy, because sometimes they can be off. If it's not a reputable pharmacy, they're not regulated quite the way that drugs you get from the main pharmacy are. I personally ended up using a micro taper method, using a high precision scale, and I would just file and weigh. I happen to be particularly sensitive, and that's the way I needed to do my reductions.
So great comments. Any other suggestions on opportunities to improving safe prescribing? And let me, before we wrap up, two other questions. One on education. So we've talked about educational gaps. And we've talked about educational resources to fill those gaps. Any additional resources that you all would really like to see to help address some of the challenges that you've been describing in this panel?
I think prescriber education on safe prescribing in terms of number of days that would be appropriate under certain conditions, and limiting the number of tablets and refills dispensed. I know I personally, like Chrissy, had an experience where I used a benzodiazepine in hospital and asked for 5 tablets to go home, and the physician insisted on writing for 30 tablets. So when I went to the pharmacy, I said, just give me 5. But most people would know to do that.
Yeah. Great, thank you.
I think it might be useful too to have information about tapering in specific populations and more evidence-based information about tapering, because it sounds like that's a challenge across the board.
Yeah, specific populations, and then guidance around how to adjust tapering based on the circumstances and the experience for that, the lived experience for that patient. Great points. And then just a final question. If there were some further restrictions on some subset or some part of the benzodiazepine class or some other types of additional restrictions, do you all see any particular concerns, unintended consequences, adverse consequences for health? There have been some questions in the chat too about understanding that there are some real risks associated with these products, but also pointing out, for example, the fact that many patients do well on them and they provide some important benefits too. If there were any further restrictions, what kinds of unintended consequences would you most want to watch for?
I would be concerned about patients being cut off too quickly or just cut off abruptly. We've seen that. I think since the opioid crisis has been ongoing, benzodiazepines, removing patients from benzodiazepines has sort of been a side effect of that. We get emails quite frequently at my advocacy organization. The patients just can't find a doctor to prescribe anymore, even though they're just trying to taper off the drug. So, I think that would be a huge problem.
And Justin Turner and Jay Shaw published a paper last year looking at different policies internationally that had been used for benzodiazepine reduction and the impacts of those policies. And I know they showed, for example, that limiting, taking alprazolam off formulary just increased the use of other benzodiazepines and drove the street price of alprazolam up. The most effective intervention was actually in Denmark, where they limited the ability to get a driver's license if you were over 65 and taking a benzodiazepine. And that reduced benzodiazepine use by over 10% very quickly.
Thank you. All right, well, I want to thank all of you for an excellent discussion, for staying on a few minutes longer to continue exploring some of these very important topics. We are going to take a break now. We're scheduled to start at 3. I want to make sure people have time for a real break, so maybe we can aim for 3:03 or so, sort of split the difference. Our next panel is going to focus on pulling together the perspectives and discussions we've had to get back to the overall focus on balancing the benefits and risks of benzodiazepines. So thank you all very much for great discussion so far today, and see you again around 3:03 or so Eastern time. Right, I'd like to welcome everyone back after our last lively session, which ran a little bit over, to this final session of today's webinar on balancing the benefits and risks of benzodiazepines. To wrap up the workshop, we've got a final set of expert panelists, some familiar faces here that will help us synthesize some of the key themes and points that came up in the meeting. We're going to focus on discussing takeaways, including gaps in data, gaps in research, gaps in understanding, gaps in supports that could help address these issues. And we're also going to have a little time, as before, for audience questions and comments after the panelist remarks. So we've gotten a lot of questions and comments in already. Please keep those coming as you listen to this discussion. Our panelists for this final session are Kurt Kroenke, who again is Chancellor's Professor of Medicine at Indiana University and a research scientist at the Regenstrief Institute. He'll give the final presentation of this session. Wilson Compton, Deputy Director of the National Institute on Drug Abuse, the National Institute of Health, will be joining us again. Chinyere Ogbonna, who is Medical Director, again, of Addiction Medicine and Recovery Services at Kaiser Permanente San Jose and Adjunct Faculty at Stanford Health. Christy Huff, thanks for being with us on the last panel too. Christy, cardiologist and Director of Benzodiazepine Information Center. Mark Stone, Deputy Director for Safety in the FDA Division of Psychiatry, and Marta Sokolovska, who is the Associate Director for Controlled Substances in FDA's Center for Drug Evaluation and Research. So first, we're going to begin with a presentation from Kurt.
Thanks, Mark. And I know we're limited to 5 minutes, so I'm going to make 9 points in 5 minutes, call it lightning rounds. First, anxiety is an enormous public health problem. It's 1 in 6 in the general population have it. It's the second most common mental disorder and the 5th most disabling condition, with only depression and several pain conditions ahead of it. Number 2, there's lots of evidence for short-term benefits of benzos for anxiety. There have been more than 70 to 80 randomized clinical trials for generalized anxiety disorder and panic. In fact, that's why it has an FDA indication. Third, I want to address the common caveat of, quote, no long-term evidence, which is true. You got to recognize most symptom-based treatments for things like pain and anxiety don't have long-term evidence. There's not incentives for pharmaceutical companies to conduct 12 to 24-month trials. And so the ability to get long-term evidence, we had one example of 12 months of CBT, but in general, we lack long-term evidence for a lot of treatments, and we generalize from short-term evidence. You might say that millions of benzodiazepine users either indicates it's benefiting their anxiety or they're dependent on it, and it's hard to separate that out. Number 4, it's not always antidepressants, CBT, or benzos. There's a good systematic review showing that in more chronic disorders, combined treatments are needed. STAR-D showed that was the case for depression. Monotherapy was seldom the treatment. Monotherapy, by the way, is the exception rather than the rule for things like hypertension and diabetes as well. So we don't want to take too many things off our menu for people who have chronic severe anxiety. The 5th point of 9 is we got to be cautious of blaming the innocent, which is we did for opiates. we sort of conflated individual and public health. We realize drugs are a problem in our society, but there are many responsible users of things for opiates and benzos, and we got to be cautious that they don't get built into the argument. In fact, I argue both for pain and for anxiety, there's almost a double stigma that patients with pain were stigmatized, and then when they were on opiates, they were doubly stigmatized. We got to be cautious we don't do this with anxiety and benzos. The sixth issue is most of this is going to be implemented in primary care. Most anxiety, probably 70%, is seen in primary care. In the brief 15 to 20-minute visits they have multiple other medical problems, preventive medicine, and things they're doing. So anxiety is only part of the agenda. Education has been mentioned. It's critical, and tools, it's not enough. What takes time in primary care is the conversations, the time it takes to talk to patients, get consent about patients, monitoring them for long periods of time. That's not currently built into the reimbursement system. 7, what does dependency mean? At the group level, we actually don't know how many people who are on benzos are dependent on it, whether it's treating their disorders. As an analogy, people with diabetes and high blood pressure are, quote, dependent on their medicines. If you take their medicines away, their blood sugar will go up and their blood pressure will go up. So we don't know when we take benzos away how often the condition that they're being treated for is being inadequately treated. Number 8, really be careful of using a heavy-handed approaches. Particularly, I would hope that with this, the DEA and state legislators would take a different approach than happened with opiates. If we make it too heavy-handed at the primary care level, the easiest thing to do is hang a shingle and say no benzos prescribed here, and abandonment. And that happened quite often with opiates. And number 9, and my last point, benzos are not identical to opiates. We heard yesterday they're often not the primary drug that's being used. When misused, it's often once a week or a few times a month, we heard yesterday. I'm talking about misuse. Misuse is more common in young than in older adults, we heard. And then less than 15% use it or misuse it to get a high. Most use it to relax, deal with emotions, and help with sleep. Interestingly, those are the indications for benzos. I'm not saying we should misuse it for that, but let's not let those go undertreated. That's my comments.
Thank you very much, Kurt, for staying so concise. And next is Wilson Compton.
Thank you very much. It's a pleasure to join the group this afternoon for the final wrap up and provide just a few comments. I may have a couple fewer than Dr. Krunke, but I have a number of first sort of lessons that I've gotten out of the last 2 days, which has been a terrific review of issues related to benzodiazepines. And I would say it's mostly focused on concerns, of course, and I've gotten a clear sense of those, both from the discussions today, which highlighted in particular the issues around withdrawal concerns and the issues related to long-term use of benzodiazepines. This is a bit of an observation. It's not a research question, which is what I really want to focus on primarily. But while benzodiazepines are generally not recommended long-term, and yet that's how they're often used. And so I wonder if the situation isn't like other, like some other substances where, although the goal may be temporary short-term, once people start down a certain pathway, it may continue progressively down that pathway. Withdrawal is not the same as addiction. I think we discussed that yesterday, but I wanted to reemphasize that again. And so the misclassification of patients that experience withdrawal syndromes, I think was highlighted again today, that patients who experience withdrawal, which is an expected side effect of too abrupt a discontinuation or dose reduction of benzodiazepines, does not mean that they are addicted to these substances, but it certainly indicates that they have a serious clinical situation that requires care. I was really struck by the limited knowledge about de-prescribing. This was brought to the attention of the field when it comes to opioids a few years ago because of the major push to reduce prescribing of opioids meant that physicians often just stopped opioids for patients. And while the withdrawal from opioids may not have actually as serious a complication as withdrawal from benzodiazepines can, it certainly produces a tremendous amount of misery as well. And so helping clinicians understand the risks of withdrawal and understand the best practices when it comes to reducing dosages and tapering and other ways to de-prescribe is a key challenge and goal. I was impressed by FDA's comments today about stakeholder engagement and how important, and I think this entire meeting suggests the importance of stakeholder engagement to FDA and really to all of us in the federal government to make sure that the decisions and policies and practices and research that we implement is likely to have benefit and not produce unexpected complications. Now, in terms of sort of things that I want to take away in terms of a research program, because that's my goal at the National Institute on Drug Abuse, I'd say, as I already mentioned, some understanding of de-prescribing or best practices when it comes to tapering is a major challenge, and how to communicate that effectively to busy clinicians, because it's easy to just say, I will stop doing this, but to do that safely and effectively is not so simple. I had a real question from yesterday that I didn't hear reflected today as much, but I do think the question about how much do the specific benzodiazepines vary from one another in terms of their effects and their outcomes is a bit unanswered. And so I would like to see some work that helps separate particularly the effect of alprazolam, which looks like somewhat of a special case. I would also point out that I was able to refresh my memory, and there is an old literature suggesting that diazepam enters the brain more rapidly than some of the first generation benzodiazepines, the very earliest ones. This is research going back 30 some years. And so that might help explain why in a previous generation, diazepam was particularly popular on the illicit marketplace. To build on Dr. Clark's comments that it's the speed with which things get into the brain that helps explain their drug liking and in some ways their abuse potential. I think qualitative or mixed methods research is needed to help us understand use patterns. That is a topic that and an approach that might help us understand how both prescribers understand the use of these substances and give us clues how best to provide practice improvements, as well as how patients or non-patients are using these substances in ways that obviously is producing a great deal of harm. And finally, we need new treatments for insomnia. In particular, I think we also need them for anxiety disorders, but I will point out that we do have some other treatments for anxiety disorders that seem reasonably effective. So I would put insomnia treatments, particularly for those with long-term chronic insomnia, at the top of the list for some research. This may have a benefit as well for other substance use disorders where rebound insomnia during periods of abstinence is a notorious predictor of relapse to whether it's alcohol, stimulants, or opioids. And so medications that don't have the intoxicating profile or the abuse potential and the potential for withdrawal syndromes as these do, if such a thing can be developed, would be a major boon to clinical practice. I think that's enough, but I look forward to hearing the rest of the comments from the group.
Thanks very much, Wilson. And next up for the group is Chinyere Ogbonna.
Yeah, thank you. So I think some takeaways that I wanted to highlight, I think really the importance of having that discussion with the patient prior to starting benzodiazepines. We have a lot of focus on de-prescribing, but it'd be great if, some patients weren't started on benzodiazepines, especially if it was not an appropriate medication to start. And we do know that in the short term, benzodiazepines can be helpful for some anxiety symptoms. But unfortunately, it does seem like a lot of the patients that we're inheriting were started on these medications, maybe didn't have all the information about some of the risks associated with initiating these medications, and end up developing physiological dependence and struggling to come off of these medications. I think the importance of not abruptly discontinuing patients who have physiologic dependence on benzodiazepines, and really focusing on building a relationship with patients, building that rapport, can certainly be challenging for patients that you're inheriting or patients that are transferred to you. And oftentimes my approach to those patients would be to, as previously mentioned, kind of plant that seed about some of the risks associated with long-term benzodiazepine use, but not necessarily take that action right away to try to get them off of it. So really just initiating that discussion, especially the first time that you're meeting with that patient. And that's a discussion that hopefully can continue with further follow-up and visits with that patient. And it may require some negotiation, as was brought up previously, especially with patients that aren't fully on board with de-prescribing. But starting that conversation, planting that seed, I think really can go a long way in not having that experience come off as being adversarial specifically to that patient. And also understanding that it may be a long process in kind of the way that we gauge success. Oftentimes we're kind of looking at that endpoint and wanting to reach that endpoint as quickly as possible. And sometimes success may be getting the patient to 50%. And that may take a little bit of time to do that. And then from there, maybe you set the next goal and continue to move forward with that individual patient. The importance of validating the patient's experiences, especially their experiences with experiencing withdrawal symptoms, common ones that we may talk to the patient about and provide that anticipatory guidance to that patient about, but also the withdrawal symptoms that may not necessarily be so common, that may appear to be bizarre or may kind of wax and wane through that process of tapering, but always coming from a place of empathy, always coming from a place of trying to understand what the patient is experiencing. And then lastly, having some flexibility. One of the gaps of knowledge that have been mentioned multiple times is not necessarily having the evidence of what is the best way to get patients off of benzodiazepines and to de-prescribe. And with that, I think there is room for flexibility, and not every patient is the same, and strategies that may work for one patient may not necessarily work for the other patient. So not approaching it in such a rigid way where it may be more challenging for the patient to be able to successfully taper off of benzodiazepines. And I really do think it's important to focus on self-efficacy, empowering patients, giving them a sense of control during this process, constantly checking in with them and letting them give you some feedback as well during that process as appropriate. Thank you.
Great. Thanks, Janine. I really appreciate the patient focus there. And next, Christy Huff.
It's not letting me start the video.
Okay, well, we can hear you, so.
Okay, I will just talk then. Okay,
there you are. Now we can see you.
So lots to unpack here, but you know, we've heard over and over again that de-prescribing guidance is pretty scant and heterogeneous. What there is, I know because I've reviewed it, trying to draft a guidance document for the Colorado Consortium. But I think the overwhelming, opinion in those guidance is that we need to be doing, a patient-led, flexible and individualized taper plan. And we certainly need more research into the patient withdrawal experience. And, I think any guidance that we come up with as far as de-prescribing needs to take the patient lived experience in mind. But I'd really like to find out who is at risk of experiencing withdrawal, especially these prolonged and difficult withdrawal syndromes that some patients in our population are experiencing. How can this be prevented and how can we best support those patients? And then I'll say again that I think physician education is key. I mean, a lot of this information is actually already out there. And now we have this recent FDA drug safety communication, but, according to what Sangeeta said earlier, the physicians haven't quite gotten the message yet. So, that's definitely a piece that needs to be worked on as well. So I think that's all I have, but thanks for letting me contribute to this conversation.
Thank you very much. Really appreciate the contributions. And next I'd like to go to Mark Stone.
Here we go. This segment was titled about looking at the benefits of risk and balance. And I would say at FDA, when we're, once a drug is approved, the primary purpose of FDA drug safety work is to inform. We seldom find information post-marketing that radically alters the risk-benefit equation. When we're looking at a drug for approval, yes, we try to see if the drug has efficacy, and once it has efficacy, we look to see if there are any safety problems that would reflect so unfavorably on the drug that it wouldn't be usable. For example, if there's other drugs that do similar things that have fewer problems or the like. But once they're on the market, it's really just a question of providing information about, and what we try to do is provide scientifically valid information on the effects of drugs on people, and we generally do that through the labeling. Now, there has been some mention at times about the REMS, and the REMS really work best when we're dealing with unusual problems requiring special treatment. So, a good example might be clozapine, where you have this, even though perhaps the biggest toxicity problem with clozapine may be more its anticholinergic effects, the unusual problem with clozapine is the risk of agranulocytosis, and that's what the REMS is built upon. Going to a longer perspective on what's been discussed here, I think the key facts I identified about benzodiazepines in trying to understand safety issues was first the similarities to opioids, in that you have little direct toxicity. You don't see much in the way of hepatotoxicity, nephrotoxicity, autoimmune reactions, and that sort of thing. You don't see a lot of much in the way of off-target effects, although I think with opioids you might point to constipation as an important off-target effect. And the primary problem in terms of acutely is an excessive effect or dosage. You've got problems with excessive sedation, driving, operating heavy machinery, impairment of reaction time, and that sort of thing. But there are also big differences. Probably the most important one is a general lack of lethality and overdose. It's very, very rare for someone to die from a pure benzodiazepine overdose. We usually see, when deaths occur, they're almost always in the case of a mixed drug overdose. And I think that's because there's a much bigger window between obtundation and respiratory depression than you see with opioids. Secondly, it's a question of withdrawal versus addiction. That people, once they've withdrawn from benzodiazepines, if they have had a problem with dependence, don't suffer so much in the way of craving and dysphoria. But I think we have to keep in mind that as Dr. Clark said yesterday, benzodiazepines are basically booze in a pill, and we certainly see a great overlap between problems with benzodiazepines and cravings for them and alcoholism. There's certainly some real parallels there. The other thing that's very important is that withdrawal was much more complicated, and that's been discussed pretty extensively. In my assessment, looking at the Ashton manual, it sounds very knowledgeable and authoritative, but when I read it, I said, okay, but where are the data? Where's this exactly coming from? How are you reaching this conclusion? And that is missing. And it's good that there are some studies about withdrawal and tapering. But I don't think we have very much in the way of answers yet. Part of the problem is that it's very hard to titrate with tablets, and that's perhaps why the tapering schedules in some of these studies are so abrupt. And I think there's probably a need for a withdrawal purpose benzodiazepine, something a little bit like buprenorphine. If you want to call benzos booze in a pill, what we kind of need is Valium in a bottle, something in a liquid form that can be titrated very, very easily. Or something that wasn't mentioned that I think is worth considering is a benzodiazepine that has a very long half-life that will allow you to taper somewhat naturally. And I've seen this, for example, with SSRIs, that patients who are on SSRIs for a long period of time often do much better when they're on fluoxetine, and because that has an extremely long half-life, and it's and once you know that the drug works and you're going to be on it for a while, it's often very, very helpful to have a long half-life, not to mention the fact that if you miss a dose, it's less of a problem. The fourth difference I think is important is that opioids are a class unto themselves. There are other analgesics like NSAIDs and acetaminophen, but they're very different in how they work, how they help people, who they help. But there are many other GABAergic CNS depressants, barbiturates, alcohol, and the so-called Z drugs, so zolpidem and Zalpun and what have you. And that is one thing I would mention in passing, that there is an important distinction to be made with the Z drugs, and that I think they were too clever by half in terms of trying to find a pharmacological answer to problems with benzodiazepines. I think that's something of a cautionary tale. And the problem that I'm pointing to is specifically a problem with parasomnias, that the effect on GABAergic receptors with the Z drugs are incomplete, and that led people walking around, while benzodiazepines actually seem to have some effectiveness in preventing parasomnias. Again, I think it's a bit of a cautionary tale. Finally, I think the sensation I've been getting through much of this program, it's a sense I get that in many ways we're looking through the wrong end of the telescope. That just looking at benzos and focusing on benzos kind of ignores how much they are just part of this collection of CNS depressants that are used and misused and abused. And substance abuse, dependence, and addiction are problems of social adaptation that are part of our culture. And chronic anxiety and insomnia are problems of social adaptation. And we try to list them as diagnoses and treat them as diseases. But I think for most patients, it's something that's belongs in a much broader context than just this is a disease, this is a disorder in physiology in some sense, and how can we ameliorate that chemically or in some other fashion. One of the things that I struggle with in looking at these questions are that patterns of drug abuse and abuse say more about the users than the drugs. I think one difficulty we had looking at when it came to the warning about combining opioids with benzodiazepines is that while there certainly was a higher incidence of fatal overdoses among people who took benzodiazepines and opioids than people who just took opioids alone, they're very different people. If I recall correctly, there were attempts to do like a propensity score controlled analysis, and it wasn't possible to do. There was so little overlap between the types of people. So it was a difficult question to say, are we really looking at a pharmacological synergy, or are we looking at just a very different population that's just prone to get into trouble with opioids, and that benzodiazepines are a signifier of that. Now, we do have some evidence now from animal models that there is some kind of synergy between them, but it's again, I think we too rarely look at results involving drugs and point to the drug as being the primary driver of the problem. I think when we think about substance abuse or questions of medical or non-medical or recreational use of drugs, I think there's a triad of perspectives. There's a criminal perspective where we try to control it through the law and to stamp out misuse that way. There's a medical perspective where you treat it by disease, and then there's this basic social concept saying, well, this is part of who we are and how do we deal with it. And I think these medications or these substances, really, because I'm not just talking about medications, fall somewhat in that triangle, among that triad, and I think are looking too much in the medical. And I think an example of how sort of obsessed we are may be what we're going through with cannabis, where we couldn't go directly from legal to kind of social and legal. We had to go through this medical step where I think even though they're helpful, the needs and the benefits of cannabis, the medical benefits of cannabis are there, but I think they're substantially exaggerated, and a lot of what's described as medical benefit has probably more to do with the fact that it has some social use. I think in many ways, we are looking at the medicalization. When we talk about benzo, we look at the medicalization of a fragment of a social program, because again, it's booze and a pill. One of the things that was pointed out was there's greater so-called medical, and I'll put those in quotations, use of benzodiazepines in older patients, compared to non-medical use. But I think that's more indicative of a greater degree of medicalization in that population. When I was a fellow, I did a study of an large elderly population, and there was a very strong inverse relationship between going to church and going to the doctor. And again, I think that sort of points to the social elements underlying this. And I think in general that there is a tendency to overuse the medical model when we see a problem, particularly when we're dealing with people like us who are trained in the medical profession and want to help people with medical problems and diseases. And I think that kind of summarizes my perspective.
Great. Thanks very much, Mark, for the thoughtful comments. And next, I'd like to turn to Marta Sokolowska.
Well, first of all, thank you very much. Can you hear me?
Yes.
So first of all, thank you very much for this very informative presentation from across the different presenters, different perspectives. It's so critical and important for us to be able to put p-values and scientific papers into more human framework, and to hear the prescribers and clinicians' perspective and patients' perspective is really valuable for us, especially when we are thinking about the balancing the risks and benefits of various treatments, including benzos, because it is a complex issue. So first of all, thank you very much for that. A lot of other panelists already summarized the key components before me, so I will not go through my list of points, just enough to say that I was really surprised about the identified need for more information regarding de-prescribing or for tapering, proper tapering of benzodiazepines. I was not aware that the need for that information is so robust, and that the need for communication education of prescribers and patients regarding this issue is so important. So definitely taking notes on this issue, and it also identifies all the different areas for research that we still need to learn more, despite the fact that benzodiazepines, old medication, relatively speaking, as was mentioned yesterday, the first ones were approved over 50 years ago. Obviously, we still have a lot to learn regarding the application of these medicines, which are very important. And when we are thinking about the risks, which is the safe use, the focus of this workshop, it's so important that we also think about the benefits of them as well, because otherwise, why would they be approved and utilized in medical practice? So I think it's a great opportunity to utilize this workshop to really think about other research opportunities across different agencies. So Wilson, looking forward to collaborating on a number of different initiatives. Could not agree more. We need to figure out how to develop and support development of new treatments that has less liabilities, but because we do have patients who need those medications, and obviously further support of the initiative through our PACE organization, BAA, safe use initiatives. Hopefully we can develop these collaborations even further. And something that Mark has mentioned briefly, as well as other presenters, especially yesterday, when we are thinking about benzos, today we've been thinking a lot about how to properly prescribe and use and administer benzos on its own. But what we recognize is that the serious risks and death related to benzos is frequently associated with co-use with opioids or other substances, that other depressants. So as we are thinking about it, and as FDA is putting together communication, try to strengthen the safety information in our labels. For instance, in 2016, we already put out warning regarding the serious risks and death when combining opioid pain medication as well as benzos, and we put a box warning on benzodiazepines. It's important to think about the broader context and the potential benefit and risks of each of these actions. Because the following year, we have released another safety communication stressing the importance of not withholding opioid use disorder medication from patients just because they are using benzodiazepines or CNS depressants, rather than just withholding the opioid use disorder treatment from them, making sure that there is more discussion regarding the careful use of those medication or prescribing of those medication and risk management to assure that these patients are being taken care of one person at a time and that they needs are being addressed. So just with that, I'm again looking forward to hearing more and addressing any other questions that there might be. But I really appreciate all the thoughts and on all the comments that we've heard so far. Thank you.
Well, thanks very much, Marta, and thanks all of you for really bringing together some of the key themes and ideas about where to go from here that have emerged from the discussions over the last 2 days. One thing that I would like to make sure we're covering is, as always, especially in complex areas like this one, even though the drug class is over 50 years old, as Marta said, there are still some very important unanswered questions on that. Wilson, but also others of you did a nice job of providing a list of those, including further research on effective tapering strategies, further research on differences in across products within the class, or some more good suggestions in the Q&A, for example, on improved genomic research as another way of getting to more predictive medicine for what kind of prescribing and what kinds of tapering might be more or less effective for different kinds of patients where the risk benefit profile likely differs. Wondering if you all have any other thoughts you'd like to add to the research agenda emerging from this effort. For example, one of the things that struck me was the importance that many of the practitioners place in the patients on needing a team approach. This is awfully hard for a single busy primary care doctor to manage by themselves. And we saw some examples, including the Louisville clinic mentioned yesterday, that adopted more of a holistic strategy. And I wonder if there are opportunities for studying not just individual changes, but systemic approaches to manage managing diverse populations, both in terms of appropriate prescribing and then effective de-prescribing strategies. But just wonder if any of the panelists have any additional comments they'd like to make about the takeaways for the practical research agenda on risk benefit from here.
Well, I would comment as a health services researcher, and maybe analogous to probably not the degree of money, but the HEAL initiative, which happened for opiates. I mean, if we're going to take this, if we all take this seriously, maybe some funding from the NIH or NIDA or other places that look at models for dealing with benzos. In some cases, it might be de-prescribing and so forth. There's a lot of evidence that collaborative care models and team models work better for depression and pain. And that's being tested for opiates, but it's not being done with benzos. Because from what all I've heard, if much of this happens in primary care, it has to be done in a way that the primary care physician can do it. And that's going to be largely with team support.
Yeah, it does seem like we are moving more primary care into team context, technology supported and so forth. And just as you said, we're seeing more research and care models in that direction for pain management, for opioid, and substance use disorder treatments, but not so much here yet. Other suggestions?
I just want to make sure that we're including the patient lived experience piece in anything we do with de-prescribing. I mean, for instance, I'm participating in a study right now with some researchers in Ireland, and we worked to identify different barriers to tapering and, things that would be successful and, from the patient perspective.
And just to follow up on that, Christy, any particular findings so far that are emerging from that, important considerations in the practical barriers to de-prescribing?
Yeah, so I think lack of support was a big one. So, I mean, we talked about support, we talked about education, both the physicians, patients, and family members. We talked about the need for patients to journal about their experience, keep track of their taper and keep track of their symptoms and, the emotions they were going through. So it's still pretty preliminary, but I think it has potential to develop a good tool for de-prescribing because it's really going to be centered on the patient experience.
Certainly some important dimensions beyond genomics around social supports, resources, and so forth that clearly seem like they would make a difference. Yeah. Other suggestions?
Well, I'd want to point out a couple of things. One, Kurt mentioned the tremendous increase in support for opioid-related research, and we have been benefiting from congressional appropriations in that regard that are pretty specific to opioids. There has been some opening with that to allow both NIH and some of the service delivery systems to focus on stimulants as part of that. But it's been difficult to reconcile the nature of polydrug use in this population with the specificity of the funding lines. And so this is a bit of a challenge for us, but there may be opportunities to look at how benzodiazepines overlap to a certain extent in the treatment of pain, because that's about half of our HEAL initiative portfolio, or in the treatment of overdose, in issues related to overdose and addiction to opioids. Those are the main themes for HEAL. I would say that Marta and I may be able to put our heads together. There's been some interesting collaborative work to look at how all the different modeling groups, and by that I mean there are a number of policy modeling groups that NIH has funded over the years, whether that's the Stanford group, the Yale group, and many others, particularly in the HIV space, that have retooled some of their efforts to focus on policy issues related to the opioid overdose crisis in recent years. And in some ways, the techniques and approaches that these folks use might be retooled with marginal effort. I mean, nothing is without a lot of work, but it sounds conceivable to me to pose some of these questions to those groups. There's some other specific work that CDC has supported, that FDA has supported, and we've been working across agencies to look at ways that these modeling groups can build on each other's work and programs. And I think adding benzodiazepines as part of their questions is a natural fit. given the overlap with overdose, but really in terms of the specific use related to benzos that have been raised in these last 2 days.
And really interesting. And just kind of picking up on Christy's comment about the importance of incorporating patient lived experience in that, just would pass along one of the comments from our audience, noting that because of this this uncertainty and limited evidence from the medical community about tapering, there are a number of patient forums that, according to Angela, who provided the comment, have already created safe taper methods themselves. Please look at this knowledge as you think about beginning new studies and research in this area. Yeah, other comments on research?
I just wanted to second Angela's statement. I learned how to taper myself off benzodiazepines from internet forums. I didn't learn it from my doctor. And, you know, I'm a physician and I had to go to the internet. So what she's saying is true.
That's good to emphasize, and something can hopefully inform the further work here too. So thanks, Angela, for that. Other questions, or sorry, other comments about research and key opportunities to learn. This has been great. If not, we've just got a few minutes left. I think it wouldn't be an FDA forum if we didn't talk a little bit about potential issues related to not just research, but also label changes. Is it time for a closer FDA look based on what we know now about labeling that's more explicit about tapering issues? Would that be a useful complement at this point to some of the other steps that we've talked about on promoting safe use and complementing the labeling information on appropriate use? There's still more that we need to learn.
I'm not so familiar with labeling, and I think the label that Jana shared yesterday talked something about tapering, but I think it would be good to strengthen the message about cautions as far as tapering, because sometimes the message comes strongly about cautions of use and risk, and less about the cautions of tapering. And I hate to bang the opiate drum, but even the CDC and others afterwards realized that there hadn't been a cautionary notes enough about if you're going to discontinue, to do it carefully, slowly, in a patient-centered fashion. That's not the language you're going to use, but it's really, and I would think it would have some strength in an FDA label, because there'd be less abandonment going on, because the drug would also not only be cautious in using, but be cautious in stopping to use.
So I'm not sure if, Mark, you want to provide more information regarding the most recent label update. However, in the recent update just from earlier this year, we have included information regarding the risk of benzodiazepines misuse, abuse, and potential other negative consequences. But we also have included in there short but a statement regarding strengthen the statement regarding withdrawal and tapering. So it's there, but I think that based on the discussion today, it appears that there might be additional opportunities, maybe not to include it in label, because from what I've seen, the tapering guidance is typically fairly long, and the labels are already lengthy as it is. So trying to think if there are any potential other venues where we can include some of that information, or at least educate on such information, because I definitely have it as one of my action items to further work on defining documentation and help educating the prescribers regarding tapering.
And Mark, I'd appreciate any further comments you have about the recent label changes and this topic more generally. And while Mark's maybe commenting on that, before we wrap up, just for the rest of you, think about to Marta's point, other ways that FDA can support safer use, including safer tapering approaches. For example, we heard earlier today about the FDA Safe Use Initiative, which is looking for more partnership opportunities around promoting a safe use of medications generally, and benzodiazepines in particular. Are there any additional projects there that might be helpful based on this discussion? But Mark, I wonder if you have any comments about the prescription information.
Yeah, I think the main point of the box warning was not like we suddenly discovered this problem, but we also felt like the problem was kind of out of sight, out of mind. That that a lot of the chronic use and dependence is done in people that are still pretty well adapted, and we only start to notice the problem when you try to stop the drug. So I think it was important to reemphasize the problems with these drugs, the fact that chronic use is often not benign, and put that emphasis there. As far as the questions about tapering, I think it was very difficult to come up with anything to say concisely about it, in particular because I don't think the evidence that we have is that good or that specific. I think there are some general, certainly we have some general notions, but a lot of it is based on anecdotal experience. And we reached out to the sponsors to see if they could supply us with any information that was specific to their products. We didn't hear very much from them. And so, like I said, I think it probably would be very useful to turn this into a focused area of research, and in terms of developing treatments. In fact, there's certainly a possibility that you could come up with a form that would be appealing to industry in terms of being remunerative. But even if that's not the case, certainly we have National Institute funds and things like that that could be applied to those questions.
Great, thank you. And Stephen, I see you've got your hand up.
Yeah, I think the question as to what might be included in the box warning is a very interesting one. And I would just like to throw out a consideration that for most situations that duration of use be limited to 2 to 4 weeks. I know that's a complex issue and it varies according to the treatment, medical condition being treated, but it's one that I think is well worth considering.
Yeah, and it's also pretty hard to be specific about that specific when you're dealing with the class of drugs that have different differences in their pharmacokinetics and those issues as well.
Great, thanks. Any other further thoughts on opportunities for collaboration with FDA on improving supports in this area, like through the Safe Use Initiative? I think we've had a lot of good ideas already.
Understanding the drug interactions is very important because of the fact that they are being co-used so frequently. So I think that could be a potential area of learning more as well.
Great, thank you. And I know we're almost out of time, but I'd want to acknowledge we got to a lot of the questions. There are also some really thoughtful comments and personal comments in the Q&A, which we'll certainly take and pass along as part of the wrap up and summary materials from this meeting. Really appreciate not only the panelists who have helped with this session and helped with the whole set of activities over the last couple of days, but also all of you who have joined us and providing some very valuable perspectives as well. So with that, I do want to just go through the formal thanks for everyone who helped put this together, not just our session 4 panelists for their insights and bringing together some key themes and points, but everyone over the last couple of days, all of our panelists, all of our active participants from our audiences over the last 2 days. It's been great to see this all come together. This doesn't just happen. A lot of work went into it from our collaborators at the U.S. Food and Drug Administration and there. I'd like to extend a special thanks to Carolyn Huang at FDA for her lead role in helping to develop today's meeting, as well as the whole planning team at FDA who were very actively involved in the guidance and preparation for today's workshop. And last but definitely not least, I want to thank our team at Duke Margolis, Adam Kretsch, Mira Gill, Thomas Rhodes, Kaylee Probst, Marianne Hamilton Lopez, Morgan Romine, Luke DeRocher, and Patty Green for all of their efforts in organizing the workshop. As I mentioned at the beginning, the speaker slides and a recording of this two-day meeting are going to be available on the Duke Margolis website later this week, so check back for that. And before we wrap, I just want to say thanks again to all of you for being with us yesterday, for being with us today, and for all that you're doing to contribute to improving how well we're all doing in terms of the safe use of benzodiazepines from clinical, regulatory, public health, and most importantly, patient perspectives. I hope you all have a good rest of the day and take care.